महागणपतिं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं कोटि प्रकाशं शान्तं महाकाव्यनाटकादिप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदक.
I now invite our first guest speaker for the day, Dr. T. Karthik Bharadwaj, MD Pediatrics, DNB Medical Genetics from NIMS, Principal Clinical Geneticist at CCMB, Uppal.
Good morning, everyone. So at the outset, I would like to thank the organizers for giving me this opportunity. This place actually has a very special connect. As a child, I used to kind of live here before this building was made 20 years back. And then I used to frequent the hospital because my aunt was working here. So without wasting much time, then I'd like to proceed to my topic today. So that slide is gone. Sorry. So I would be speaking on genetics of congenital deafness. Though the topic is primarily restricted to congenital deafness, I would be speaking about few syndromes which cause childhood onset deafness also. Just give me a second. So briefly, today's topic I have divided into a brief introduction, a very brief one actually, which looks at the causes and the percentage of each cause the congenital deafness, an approach to a child with deafness, and I'll be taking you around with few syndromic and non-syndromic hearing losses, and then and how to work up these, especially genetic, and then counseling. So many of the slides are quite busy, but I thought instead of keeping empty slides, keeping them busy is better. So as you all know, congenital deafness is the most common sensory disorder worldwide. And then profound hearing loss in newborns affects up to 1 in 1,000 to 1 in 2,000 newborns worldwide. And then the prevalence of hearing loss actually increases as you include more age groups into it. So it has lifelong implications on the child and also on the family because of deficits in speech and language acquisition, which results in poor academic performance, difficulties with personal and social life, and also emotional difficulties. So the causes of congenital deafness can be divided into environmental and genetic, roughly 50% contributing to each. Environmental, you are well aware, torch infections, ototoxic drugs, prematurity, and other insults to the central nervous system can cause deafness. And then in genetic, it can be further classified as syndromic or non-syndromic. Syndromic is where other systems are also affected along with hearing loss. So some of the commonest syndrome that you would all be aware would be the Pendred syndrome, Usher syndrome, Waardenburg syndrome. Some of these we would be going through in the future slides. And then non-syndromic hearing loss, the hearing loss is the only manifestation of the genetic mutation, and there are no other features. So in that, recessive forms of hearing loss are the most commonest, constituting about 80% of non-syndromes, quiet to mother's voice, Then a lot of lists is there that you can go through. You can have checklists also. And it's important to evaluate other spheres of development also, because there are a lot of neurodevelopmental, and it could be probably a autism spectrum disorders. The child is just not speaking because of another abnormality which is not related to hearing loss. So some of these milestones, if they are not achieved at a particular time, are actually red flag signs for further evaluation. So at 12 months, if the child is not babbling, pointing or gesturing, and then at 15 months, if he is not able to use at least 3 words, and at 18 months, mama, dada does not come out. And the list goes on actually. These are all available in various sources, though the age kind of differs between different recommendations. So you can use CDC recommendations to kind of identify these red flags and put child for further evaluation if these are present. So not only being able to achieve a milestone, it's also important to see if the clarity of speech is there. As the age grows, a child having less than 80% clarity in speech at around 5-6 years might be a clue towards hearing impairment. So that's also something that needs to be taken care of. And sometimes the parents may just complain that the child is raising the TV volume too high every time he switches on the TV. So these are the things that children usually come, or the parents usually come to you with. And then once you have the clinical suspicion, then you'll have to kind of confirm the hearing loss by physiological tests. And these are the tests that you are more aware of than me. Pure tone audiometry may be more easier in the older children when compared to the younger ones. So evoked autoacoustic emissions for newborn hearing screening, then auditory brainstem responses, steady state response is kind of catching up, then PTA and then emittance testing are important to kind of know the conductive pathways. And then sometimes these audiogram patterns may also be a clue to what is the underlying cause. So low frequency hearing loss is usually unusual. Most of these genetic syndromes have high frequency, mid frequency. So, and if it is present, it can indicate involvement of WFS1 gene or HDI-A1 gene. And then U-shaped or cookie bite, it might be present in autosomal dominant hearing losses, especially those associated with COL11A2 and TECTA genes. And then sky slope pattern in TMPRSS3A gene. So, and then after you establish that the child has hearing loss, then it's important to differentiate whether it is acquired or inherited, and also whether it is syndromic or non-syndromic. So for this, you'll have to go into medical and birth history, prenatal, perinatal histories, take a detailed pedigree, do a dysmorphologic evaluation, and go for further investigations. So in prenatal history, you need to ask about infections of signs and symptoms of torch infections. So you can have maternal fever, rash, arthritis. Sometimes these may not be present also. And then if any torch status was done in the child, in the mother during pregnancy, and then viral cultures and PCR studies at birth. Sometimes other evidences of perinatal infection can be there, like intrauterine growth retardation and hepatic calcifications, CNS calcifications. So all those things to be taken care of and carefully noted in the prenatal history. And then coming to perinatal, again, you'll have to see whether the baby has grown well or not. So low birth weight can be seen in many of these genetic syndromes, chromosomal disorders and copy number variants. And then there are any other risk factors like NICU admission, mechanical hyperventilation. So there is a significant association between prolonged mechanical ventilation or ECMO with hearing loss. And then if there is any history of hyperbilirubinemia, which results in auditory neuropathy, and then any history of treatment with aminoglycosides for any reason. So these, and then hypothyroidism can also be there and associated in certain syndromes. In postnatal, again, you look at postnatal risk factors which primarily kind of affect the CNS. So viral illnesses, bacterial meningitis. So with the advent of good medical facilities and all, these causes are actually coming down. And in developed countries, at least, these are not any more common. And like some interventions like using steroids while treating Neisseria meningitis and other things have in fact reduced occurrence of hearing loss later. So, and coming to the family history, a detailed pedigree is important, especially because many of these can be genetic cases. And then if there is consanguinity, it can indicate possibility of autosomal recessive disorders. And many of these disorders have variable expressivity in the sense that some features are present in a few members of the family while your patient comes with a different feature, and all belong to a single syndrome. And then ethnicity and country of the origin are also very important, because certain specific mutations are more commoner. So when you're going for genetic testing, you can kind of test for those mutations only initially to save money and kind of diagnose the disease. Then this information also helps us in arriving at a pattern of hearing loss, whether it is dominant, recessive, inheritance pattern, autosomal dominant, recessive, or X-linked or mitochondrial, which in fact helps us in kind of shortlisting the number of genes that we need to study in the future. Then audiometric characteristics of other family members, if any, should be noted. And then evidence of vestibular dysfunction. As I said earlier, some syndromes can have vestibular dysfunction. And then because of the variable expressivity again, you should ask for other features apart from deafness, which can be present in the family members. Then coming to syndromic deafness, so some of the clues are visual abnormalities, heterochromia iridis, Waardenburg syndrome, retinitis pigmentosa, Usher syndrome, and some ciliopathies like Bardet Biedl, Alstrom syndrome can have retinitis pigmentosa. There are certain skeletal dysplasias which predispose to myopia, retinal detachment, and Alport syndrome with congenital cataracts. Then you'll have to take a detailed dysmorphology evaluation. So it's a big thing. It's my job actually to do a dysmorphic evaluation. So these are clues to different syndromes. Some of these you'll be seeing in the future slides. And then these are sometimes these can be associated with endocrine abnormalities like thyromegaly and diabetes in syndromes like BRID-MOD, that is diabetes insipidus, diabetes mellitus, and deafness, and maternally inherited diabetes mellitus and deafness syndromes. And then sometimes you'll have to, you can have a family history of sudden deaths or syncopal attacks, and some of these can actually come to, have been diagnosed as a seizure disorder. Sometimes atonic attacks can mimic sudden syncopal episodes. These might indicate regarding important finding of prolonged QT interval that occurs in a syndrome which affects the potassium channels, both in the heart and also in the cochlea. So it's important to know about this because this is something which is preventable, and we'll be covering the syndrome in the future slides as well. And the age-old thing, you have ear abnormalities, you'll need to look at kidneys. It also is true because they develop at similar developmental timelines during embryonal period. And then inquiring about hematuria, proteinuria, and then imaging for any structural defects is also important. And then you have syndromes like Waardenburg syndrome, which have premature graying and a white forelock. And abnormal pigmentations of the skin, which can give rise to, which can give a clue to like neurofibromatosis type 2, or dry skin or keratoderma, which can be an indicator for a syndrome called KID syndrome, so which includes keratitis, ichthyosis, and deafness as major components. So after you look at those clues and kind of try to do a literature search and fit in the patient's disease into a certain syndrome. So we'll briefly go to details of certain common syndromes which have hearing loss as a predominant feature. Though there are more than 400 genetic diseases which have which is in hearing loss as a symptom, these syndromes have hearing loss as a major component. So this is something that you all know, very common cause of autosomal dominant hearing loss. So dystopia canthorum, pinched nose, heterochromia iridis, then abnormal pigmentation of skin and hair. These are all features. It's a highly penetrant disease, but there is a lot of variable expressivity as well. So in some family members, you'll not have deafness, only heterochromia iridis is present. Some family members, you just have whitening of the forelock, nothing else is there. And then you get a child with congenital deafness. It is genetically heterogeneous, means multiple genes are causative of the disease, and there are different types also, type 1 to 4. And then maybe you need not know about the different types of Waardenburg syndrome, but orthological characters are, they can have hypoplastic ear cartilage, abnormal vestibular function, especially in type 2. And then they have bilateral sensory neural hearing loss, and the low mid-frequency loss. And then cochlear implantation can actually yield a good benefit in these patients. Then the other common syndrome which is associated with congenital hearing loss is branchio-otorenal syndrome. And as the name suggests, it has branchial arch abnormalities belonging to the second arch, and then ear abnormalities and also the renal abnormalities. So there are different criteria. It is caused by, in most cases, it is caused by mutation in EYA1 gene. And now a couple of other genes have also been discovered. So there are major and minor criteria to kind of diagnose the disease. So then hearing impairment is estimated to present in about 70 to 90% of cases with variable age of onset. And then it's either sensory neural hearing loss, conductive hearing loss, or mixed. And then Montanus dysplasia can be sometimes identified in the neuroimaging scans in this disease. So other external ear abnormalities can also be seen. And then in the picture you can see that finger actually pointing out to the branchial sinus. Then Stickler syndrome is another common skeletal dysplasia that we see, which actually has some dysmorphism along with Pierre-Robin syndrome. They have significant eye involvement in the form of myopia and early retinal detachment. They have joint laxity. This actually happens because of mutations in collagen-associated genes. And then in this also there are different types, and then a lot of genes are also involved which causes this syndrome. And this actually has hearing loss as a significant component. And the other autosomal dominant common syndrome that we see is Stretcher-Collins syndrome. It's actually a dysostosis, mandibular facial dysostosis. Most cases again caused by TCOF gene mutations. And there are other genes also, a couple of others which are now associated with disease. Then you have these typical features of microtia, malformed ears, then mid-face hypoplasia, micrognathia, downslanting palpebral fissures, and coloboma of outer one-third of lower eyelids. This is a gestalt diagnosis. You see the face and you recognize the syndrome. And this also has lot of variable expressivity, in the sense some subtle features can be present in the parents, and then they are completely unaffected. In addition, these children also have very narrow airways, predisposing them to obstructive sleep apnea and sudden infant death syndrome. Hearing loss in this is usually conductive, but sometimes sensory neural hearing loss is also present. And so another syndrome is neurofibromatosis type 2. You all know it predisposes to various kind of neurological tumors. Then presence of bilateral schwannomas is a strong indicator for auditory nerve schwannomas is a strong indicator for neurofibromatosis type 2. So there are again criteria to diagnose this syndrome, but it is something which can present with progressive unilateral hearing loss initially and then convert to bilateral. And then if you see Café spots, a few of them, and then on neuroimaging you find meningiomas, ependymomas, gliomas, then the most obvious diagnosis would be neurofibromatosis type 2. And another group of disorders would be skeletal dysplasias, osteogenesis imperfecta with fragile bones, blue skierae, and hearing impairment. Hearing impairment is usually in the second or third decade. And then it can be conductive, and in fact this is something that I also learned new. Sensory neural hearing loss can also occur. That is because of cochlear hair cell atrophy and atrophy of stria vascularis. Then going to autosomal recessive syndromes, and so Usher syndrome is the most commonest one, which causes retinitis pigmentosa along with blindness. So it's also pretty common. And then here also multiple genes are involved. More than 15 now actually are associated with Usher syndrome. And clinically it is divided into three types: type 1, type 2, and type 3. Type 1 actually has severe vestibular dysfunction and motor delays in the early childhood. And then onset of retinitis pigmentosa is more consistent and happens earlier in the childhood when compared to the other two, which are relatively benign when compared to type 1. So in this, ocular changes can actually happen later, usually during puberty and all. But you can do an ERG even in the first or second year to identify retinal abnormalities. ERG in the sense electroretinogram. Then you have Pendred syndrome, which is characterized by abnormal iodine metabolism. Very classic thing that has been described since your MBBS days. So it presents with severe sensorineural hearing loss, usually present at birth, or it can be progressive. And then it has inner ear abnormalities also sometimes, especially dilated vestibular ducts. And then goiter usually develops at puberty. Sometimes imaging therefore is important in the initial days before the child goes to puberty to document thyroid abnormalities and also dilated vestibular ducts in the cochlear region, which gives a clue towards this syndrome. And then it need not always be hypothyroid. So sometimes euthyroid goiter can also be there. And this is one important syndrome because Jervell-Lange-Nielsen syndrome, it has prolonged QT interval on ECG, which predisposes the children to have torsades de pointes. So it's important to look for syncopal attacks or sudden deaths in the family. And the death can be therefore be prevented by implanting an ICD and taking necessary precautions. So these also have a good prognosis with cochlear implantation, and most of them having sensorineural hearing loss. And this is another thing which is important, though usually it is multi-systemic in the sense it has neurodegeneration, rashes and other things. But sometimes hearing loss can be an isolated manifestation. It is important because you can treat it, and just biotin supplementations will almost cure the child without any further episodes. So if some child presents with episodic ataxia kind of thing with progressive hearing loss, then this is something that you should look for. You can do a simple enzyme assay, which is not that expensive to diagnose, and then supplement the child with biotin. Then coming to X-linked syndromes, the commonest one is Alport syndrome. In Alport syndrome also autosomal recessive and dominant forms are there, but 85% of these cases have Alports. These cases have X-linked pattern of inheritance, and this is because of mutations in COL4 gene. And then eyes typically can have congenital cataracts at birth, and then the most pathognomic feature would be the anterior lenticonus, which can develop later on. And you have renal abnormalities in the form of glomerulonephritis, hematuria. Microscopic hematuria can be present in the childhood, which later manifests as a gross hematuria. And then in ears, and you'll have bilateral progressive sensorineural hearing loss. Here it is not congenital, it's usually after the second decade that it manifests. Then after the syndromes, we'd go to the non-syndromic hearing loss. This is a picture showing some of the important components of the functional components of the cochlea and the proteins that are involved in many of these non-syndromic hearing losses. So you have these gap junction proteins, and then you have various kind of transporters which transport ions from into or out of endolymph. And then you have those machinery which operates the cilia on the hair cells. So some muscle fibers are also involved. So most of these non-syndromic hearing loss kind of affects genes involved in these proteins. So a special mention has to be there for these commonest forms of non-syndromic hearing loss. So connexin 26 and connexin 30, alternatively called as GJB2, GJB6, are the most commonest genes involved in non-syndromic hearing loss. So up to 50% of cases with autosomal recessive prelingual NSHL and 10 to 40% of sporadic cases involve this locus, that is DFNB1 locus. And then there are some population specific. Earlier, as I was telling, ethnicity is important because these mutations are actually PW77X, that is, it's a stop gain mutation, and then PW25X and Q124X are the most common in Asian subcontinent. So some studies have been done on these mutations in India as well. If you do like these three mutations, the pickup rate can be as high as 30 to 40%. And then the second most commonest mutation is a 342 KB deletion, which involves GJB6 gene. This requires a slightly different kind of genetic test to diagnose. And then no structural abnormality of the cochlea or the vestibular ducts are noted in this disorders. This is a complex kind of and very essential genes for hearing, and autosomal recessive, autosomal dominant, and digenic forms of inheritance are actually are been seen with mutations in connection 26 and 30. And then now, a lot of busy slides. All these slides I've put just to show that there's a lot of genetic heterogeneity, in the sense that a lot of genes are involved in non-syndromic hearing loss. So some things like onset of the disease and then audiometric characteristics, type, progression can help in kind of narrowing to a few set of genes, but it is not usually absolute. So these are various loci which are associated with autosomal recessive non-syndromic hearing impairment. So again, a lot of genes. And then you have dominant NSHL. Again, you can see low frequency, high frequency, all these kind of audio profiles with different genes. And again, there are a lot of these genes. And then you have a lot of X-linked loci as well. And you have mitochondrial non-syndromic hearing impairment as well. So probably some would have, at least someone who has done pediatrics would have read about aminoglycoside-induced hearing loss. The child is treated for sepsis with aminoglycosides, and later on he develops hearing loss. And this 155A2G mutation is the commonest mutation that is seen in these patients. And there are these three are the important mitochondrial genes which can cause hearing loss. And in fact, some of these genes are associated with other multisystemic diseases of mitochondrial nature as well. Means they can have central nervous system dysfunction, peripheral neuropathy, and other things in association with other mutations. And a special mention on auditory neuropathy. This is recognized when OAEs are normal, but other tests indicate abnormality of auditory nerve function. So prematurity and hyperbilirubinemia are the most commonest causes. But in term baby, if you find auditory neuropathy, you'll have to look for OTOF mutations. Some of these actually have temperature sensitive mutations, which can cause later onset hearing loss. And then in syndromic forms, Charcot-Marie-Tooth disease, which causes peripheral neuropathy, can also cause neuropathy of the auditory nerve. And some of the mitochondrial mutations are also responsible for auditory neuropathy. So apart from these syndromes, there are a lot of inborn errors of metabolism, like even chromosomal disorders like Down syndrome, a group of disorders called lysosomal storage diseases, a lot of skeletal dysplasias, which can kind of lead to sclerosis of the middle ear bones, and other things which can cause palatal insufficiency or nasopharyngeal abnormalities, thereby predisposing to recurrent middle ear infections and conductive deafness are known. So workup initially should be to differentiate between acquired and genetic causes. So serology and culture for congenital infection should be done as early as possible. These things are usually informative if done before 6 weeks of age, because later on the presence of antibodies may indicate a secondary infection, not a congenital infection. And then cultures are the most sensitive and specific test for congenital CMV if done earlier. You can do it from urine cultures. Then urine analysis for blood, protein and sugar, various syndromes that I have described earlier. Then renal ultrasound to look for structural renal abnormalities. Neuroimaging to look for malformations in the temporal bone. And then ECG to look at the QT interval. Then you have a detailed ophthalmologic evaluation which is necessary to identify pigmentary retinopathy, signs of congenital infection or any developmental malformation. Then electroretinogram can be done. It can kind of help you identify before the obvious manifestation of retinopathy. Then audiometry of first degree relatives, mother and father, is also important. They can have lesser degree of hearing loss. And if another sibling is there, you have a suspicion, you'll have to go for audiometry of those children also as well. Then vestibular investigations may show hypofunction, which is seen in syndromic as well as non-syndromic hearing loss. So Usher syndrome type 1, Javel-Nielsen syndrome, Pendert syndrome, all of these can have vestibular dysfunction. And then a lot of non-syndromic hearing loss genes are also associated with vestibular dysfunction. So the next thing that after you do all this is to confirm the diagnosis using a genetic testing. The reason that we need to do the genetic testing is, once you do, you might be able to confirm a diagnosis. You can confirm a syndromic diagnosis as well, which helps you in kind of looking for other organ systems involvement, which will be particularly helpful for the child. And you can offer prenatal diagnosis in the future pregnancies of the couple based upon the information you obtain from genetic testing. So for syndromic hearing loss, after pre-test genetic counseling, depending upon the suspicion syndrome, so you think it is Down syndrome, you do a chromosomal disease. You think it's some multiple malformation dysmorphic syndrome, you can do a chromosomal microarray to look for copy number variants. And then if you think it is some gene in single gene disorder, you can go for sequencing of the single gene or a mutational hotspot in the gene, or you can go for broad spectrum tests like whole exome sequencing, clinical exome sequencing, or whole genome sequencing. So which kind of study needs to be done, it depends upon your clinical evaluation and interpretation of the data that is available to you. And then for non-syndromic hearing loss, if you have any specific indication for a single gene disorder, for example, there is a matrilineal transmission. So mothers are transmitting it to their children, but fathers in the pedigree do not transmit it to their children. It can give rise to, it can give a clue for mitochondrial kind of disease. And then you have history suggestive of aminoglycoside-induced hearing loss. Then you can specifically look for some common mutations in the mitochondrial genome, like this thing, and then you can diagnose it in the initial go itself. But if any specific indications are not present, then you have to go for a tiered approach. Means you'll have to do testing of the few commonly involved genes first, and then go for the rarer genes. So as we had seen earlier, those at the DFNB1 locus, connection 26 and 30 are the commonest genes involved. So it makes sense to kind of test for those genes before we do anything else to find out. So you might be kind of landing up the genetic diagnosis in 40 to 50% of the cases without doing any further testing. So, and if this testing is negative, then you go for panel-based testing. So multiple genes can be studied at a single time because of advent of this new technology called as next generation sequencing. So you can get information regarding multiple genes and at a single go. Then temporal bone imaging, it's actually acts as a complement to the temporal genetic testing. So sometimes you may not be able to find anything on genetic tests, and then your imaging can give certain clues also. And of course it is important prior to going for cochlear implantation. So some of these features like dilated aqueducts and vestibular enlargement are seen in Pendard syndrome, Mondinus dysplasia and branchiotorhinal syndrome. And then this POU3F4 gene mutation, it causes an X-linked deafness. It has got a pathognomic temporal bone deformity, which includes dilatation of internal auditory canal and fistulous connection between the internal auditory canal and cochlear basal ton. If I remember correctly, this kind of leads to what is called as cochlear gusher during the surgery, where the fluid gushes out when cochlear's basal ton is opened. And then it's also important if auditory neuropathy is being considered, because it can show hypoplasia of auditory nerve in many cases. And then in cases of progressive hearing loss, as in NF2, it can be diagnostic. So it's not that you end up having to find a genetic cause in every case. So sometimes you'll not be able to find it. In such a case, the child needs to be evaluated by the geneticist every 3 years. Because sometimes subtle forms of these syndromes can develop with age, and then newer tests and newer genes are being identified every day, and these genes can be studied at a later date to kind of identify the genetic etiology. So it's important to identify the clinical research concerns unrelated to the hearing loss, and for which referral to appropriate specialties is important. So take-home messages include congenital hearing loss, as you know, is etiologically and genetically heterogeneous, and all forms of inheritance are present. And it is important to differentiate between syndromic and non-syndromic hearing loss. Genetic testing is essential for prenatal diagnosis, confirming syndromic or non-syndromic deafness, and also for accurate prognostication of the child. And then at present, because the costs of NGS-based testing are coming down, multi-gene panel testing is a current preferred modality of genetic testing. So these are some of the references that I have used. And before you guys can ask me any questions, I thought I would put this question. So a couple with congenital deafness, that is both of them being affected with congenital deafness, are planning for children and come to you asking what is the chance of my child having deafness. So any guesses? What is the recurrence risk in the family? And I am specifically put this question so that I can be happy. You throw a number, it can be right. 50%. Any other thing? Throw any number. He's right. Any other number? So it can be 0%, it can be 25, it can be 50, it can be 5, 10, it can be 100% as well. So both mother and father can have a non-genetic hearing loss. The risk would be 0%. Then one can have autosomal dominant, other can have an autosomal recessive, then risk could be 50%. It can be mitochondrially inherited, then you can, it is difficult to calculate the risk even if you have a very extended pedigree. And then if both are having mutations in the same gene, so say connexin 26 mutations are present in both, then the risk to the children could be as high as 100%. So it is important to do all the steps that we have discussed in the previous slides to kind of tell what is the risk for your children. Yeah. So that ends my talk. Thank you. And then any questions I'd be able to answer.
Any questions? Anybody? I have a question. Like now we have 95% of the kids who are born congenitally deaf are born to hearing parents. So for every parent, it's a concern to know that, you know, whether their next kid will have a deaf child or not. So anyways, you have answered it that they have to do all this. So Karthik actually works with CCMB and he also visits Gandhi Hospital probably from next week for one day, and he's also planning to come to ESI also probably in the future. So I would just ask you that if you can update us, what would be the cost to a patient to do the genetic test, and how can we reach you or CCMB, and what should we tell the patient?
So at present we can actually do connexin 26 mutations only, but in a couple of months we would be having the NGS technologies also with us. So we would be doing all the genes involved in congenital deafness. So I'll be available at CCMB on most days of the week, except for Saturday and Sunday in the morning hours for clinical evaluation. And you can send the patient there. Then you can actually send the patient just for testing as well. That's not an issue. So CCMB, I'm sitting at Annexure 2 opposite Genpact at Uppal. So you can give a ref letter on my name and people will direct them to me. And then probably we can in future have a tie-up with ESI hospitals as well, so that directly you can send samples from here to the lab for getting tested. Yeah. No sir, sorry, I forgot to answer. So this is this costs around 2,500 rupees, connexin 26 mutation. Yeah. And then next generation sequencing is actually costlier. It would be around 18,000 in most cases at least. Multi-gene panel testing, that would come to around 18,000.
How can we encourage the parents for early consultation to the specialist? Any counseling, for example, parent comes with the child, how best you can counsel so that the parent will bring the child to the specialist?
So the most important incentive in these cases would be to avoid similar problem in the future pregnancies. If this is the first pregnancy or second pregnancies, or in any case if they are planning for further children, it is important for them to get the genetic testing done, because we can prevent this from happening in the future pregnancy. And the second most important thing would be if you are suspecting any syndromic etiology, because it has a significant impact on the prognosis of the child. It's not just hearing loss, but other systems are involved which require specific preventive measures, and if taken can be helpful for a better life of the child. So these are the two things that you need to tell the parents. And anyway, doing a genetic test, some of them can just be interested in knowing why this has happened to me, especially when there's nothing like this in my family before. So these three things are some things that you can tell to the parents to send to me or any other specialist.
The role of consanguinity?
So consanguinity indicates possibility of an autosomal recessive disease, but it is not absolute. It's not that if you have consanguinity, the child needs to have a recessive deafness, because some of these mutations are common in the population also, connexin 26 and 30. So, and it's not that people should not marry in consanguinity, but once something is there, it is at least prudent to prevent it in the future pregnancies.
Thank you.
Thank you.
I have a question.
Yes.
Is there any role of genetic testing in adults? We see a lot of patients with sensorineural hearing loss, sudden sensorineural hearing losses.
So some of these adult onset hearing losses are actually have some certain single gene disorders, but the more common are presbyocusis and other are considered to be multifactorial. In the sense there is genetic predisposition or also environmental causes that contribute to the disease. So in those cases, it is not necessary to go for any specific genetic testing, but young adult onset sensorineural hearing loss, yeah, we can do genetic testing.
Meaning like we have intratympanic steroid therapy, like we don't know how the patient is going to respond. So can we prognosticate the patient? Like this patient is going to respond like this?
No.
There's nothing.
As far as I know.
Okay, thanks.
I can answer your question. Actually, if you do a genetic testing for congenitally profound children or people with auditory neuropathy, then there have been studies which indicate if they have this gene anomaly, then what will be the prognosis, how well the child will do with an implant, and how will be the speech outcomes. But I don't know if for adult it is so proper, but for congenitally deaf you can tell. So adult is not common. Adult single gene based genetic etiology is not that common.
Okay, thanks.
Thank you, Dr. Karthik. That was a very informative presentation. I invite Dr. Kalyani Madam, our Professor of Anesthesia, to please come and felicitate Dr. Karthik. And our Organizing Secretary, Dr. Vijay Praveen, sir. I invite Dr. A. Lennon, Civil Assistant Surgeon at ESI Hospital, Nacharam, to please come up for the next presentation.
Right behind you. Thank you. Respected teachers, particularly Dr. L.S. Reddy, who is my teacher and is now President Association of Otolaryngologists of India, and other distinguished speakers. And my ESI colleagues, Dr. Venu and Dr. Rajshekhar, who has come all the way from Nacharam to attend this lecture, and HOD of Anesthesia Department, Dr. Kalyani, and I thank organizers of ENT Department, Dr. Yugandhar, Dr. Manu, and Dr. Vijay. So today the topic given to me was cochlear implants and candidacy and expanding indications. PPT పెడతా PPT కావాలా
దీంట్లో ఉందా
నేను పెడతాను
మర్చిపోయినా సార్ దీంట్లో ప్రాబ్లం లేదు ప్రొజెక్టర్
దానిలో
అవసరం లేదు సార్ దీంట్లో
any problem, it will take time.
2 minutes.
I think the problem is there. Problem is there. కంటిన్యూస్గా ఆన్ పెడితే బెటర్. ఆఫ్ చేయండి. ఇది తీసి పెడదామా? Okay. Now, as you all know, the cochlear implant surgery or the cochlear implant program requires the first step, that is determining the candidacy, and that is the most important first step in cochlear implant program. Before going into actual determining the cochlear implant candidacy, to make the topic interesting, and then and it is our duty also to remember the legends who have made a cochlear implant program a big success, and who has led into the future of hearing aids. And I would like to dwell some of the important points in the history. And it was Alessandro Volta in early 1800 who first inserted 2 metal rods in his own ears, and he felt that a boom within the head. That was the first recorded evidence of the electrical stimulation of the ear. And in 1885, Disney used alternating current, and he felt the sensation of the beating of flies' wings between the panes of glass and curtain. That's what he described about the passing of the current in the ear. And in Brenner in 1868, he found an important observation that hearing sensation is better using with negative polarity, and also that a reduction of unpleasant side effects achieved with correct placement of electrodes. This point is important. The Brenner first described in 1868 with the correct placement of electrodes in the ear, which can improve the hearing. And in Fleming 1930 discovered thermonic valve vacuum tube, and it is the major scientific breakthrough in speech processor discovery. And Weaver and Brain 1930 had made an important discovery in US that electric response recorded near the auditory nerve of the cat was similar to the sounds which the ear had been exposed. So the transmission of the sound through electrical impulses into the auditory brainstem, this is the basis of the study. Garshina and Volokov has made an important observation that they demonstrated that with electrical stimulation, hearing sensation still remained after removal of the tympanic membrane and ossicles. That means they proved that even without tympanic membrane and ossicles, the hearing can be possible. They theorized that cochlea was the first site of stimulation, and Stephen and Johnson in 1939 has placed electrodes in basilar membrane, and direct stimulation of auditory nerve produced a crude hearing sensation. In 1950, Lundberg stimulated auditory nerve using a neurosurgical operation. He is a neurologist, and he stimulated the auditory nerve during a neurosurgical operation. And in 1957, Jarno and Aris placed a wire directly on the auditory nerve. This was the first attempt of the prototype of cochlear implant program. And Doyle et al. Inserted electrode array 4 electrodes into the cochlea of the deaf patient and got good results. And Simmons in 1966 inserted an electrode array into the cochlea closer to the modulus. So these are some of the historical events which occurred. And in early 1970s, Michael and House, this is a major breakthrough, and insertion of electrode array through the scala tympani was done by House. And in 1972, speech processor was developed, and Rod Sanders is the first multi-channel cochlear implant patient in 1978. So these are the milestones of cochlear implant program. And why determining the candidacy? The question is, why determining the candidacy? Candidacy determination is very important first step in cochlear implant program, as I told you earlier, and to find out the right candidate at the right time for the right surgical approach and for the right results. These are the 4 reasons why we have to find out the right candidate for the cochlear implant program. Let me discuss about the problem of hearing loss or hearing disability in our country and in the whole world. So 360 million people, that is 5.3% of world population, suffer from hearing loss, and in Southeast Asia it is 4.6% to 8.8% have hearing disability. In India, 63 million people, that is almost 6.3% have hearing disability. 4 in every 1,000 children, severe to profound hearing loss was found, and almost 1 lakh babies born with hearing deficiency every year. Adult onset deafness in India is 7.6%, and childhood onset deafness is 2%. And the national sample survey done in 2002 found that it is the second most common cause of disability and topmost cause of sensory deficit. And in urban areas, it was found to be prevalence of 9%. In rural areas, it is found to be 10%. And out of them, 32% are profound and 39% are severe hearing loss. And 7% children are born with hearing disability. This problem identification signifies that we have a huge problem in our country. So regarding the hearing disability, and these statistics shows that to take this seriously, the cochlear implant program or the hearing aid program or the newborn screening, newborn hearing screening, and which will be dealt by Shivaprasad in the evening, newborn hearing screening, and all the bodies including AOA and Pediatric Association should recommend routine hearing screening with otoacoustic emissions as a mandatory, like we do certain mandatory tests immediately after birth. The OAE or newborn screening should be made compulsory. So this statistics tell the truth. And determining the candidacy is a teamwork. It is not the only job of ENT surgeon, or it is not the only job of audiologist. It is a teamwork. It requires audiologists, speech language pathologists, counselors, social workers, radiologists, otologists, and neurotologists. This teamwork is very important. And the tools which are there, which are available to determine the candidacy are pure tone audiometry, sound field audiometry, hearing aid testing and fitting, tympanometry, otoacoustic emissions, evoked response audiometry, electrocochleography, and speech perception testing in quiet and in noise, and MRI and CT. Out of all these things, speech perception testing in quiet and in noise and MRI and CT are the most important prerequisite essential tests. So these are gaining the ground in cochlear implant program, that is particularly speech perception testing in quiet and noise, which I will be dealing in the next slides. And candidacy, and it is an overview, whether it is children or adults or newborns. The candidacy overview is presented in front of you. That is severe to profound sensory neural hearing loss, limited benefit from hearing aids, no medical contraindications, strong support system, appropriate expectations. Strong support system in the sense, the cochlear implant program, as I told you, is a teamwork, and it requires the teamwork of audiologists, speech pathologists, and the counselors, and more important, the parents. And the support system also should include the parents and the teachers of the school, and entire the environment around the child should support the cochlear implant pre and post procedure. And appropriate expectations, the patients must be told, or the parents must be told what to expect and what to not to expect clearly regarding the cochlear implant, explaining them the course, prognosis, complications of the cochlear implant. And of course the child must be, and the parents must be highly motivated to maintain the cochlear implants in their maintain the cochlear implants, and to be willing to voluntarily participate in the post-cochlear implant programs. Now, age-specific candidacy. These are the points which I am going to deal with. The age-specific candidacy. In adults, less than or equal to 50% aided speech recognition in the ear to be implanted, and the speech recognition threshold is the lowest level at which the person can identify the sound from a closed set list of disyllabic words, like disyllabus, the words which contain 2 letters, ball, bat, like that. So another criteria is less than or 60% aided speech recognition in the unimplanted ear. They vary according to the implant manufacturers. There are 3 or 4 implant manufacturers which has given the criteria for the adult candidacy, and the criteria varies, but the common point among them is the first point, that is the less than or 50% aided speech recognition in the ear to be implanted. An interesting article published by Pearson et al. Has shown that average conversational speech level were 60 decibel SPL, that is sound pressure level, instead of 70 decibel SPL. Usually we consider 70 decibel SPL as the lower limit of categorizing the severe hearing loss. But Pearson et al. Has proved that average conversational speech levels were 60 decibels, that is 10 decibel less than the conventional thinking of 70 decibels. So in what he proved is, in lab testing conditions, in ideal testing conditions, 70 may be the ideal criteria for the severe hearing loss criteria, but in actual, in practice, the Pearson proved that it was 60 decibel SPL, which is the correct level of classifying this severe hearing loss. And post-implant speech recognition identical, and he also observed that post-implant speech recognition is identical for 60 and decibels sound pressure level, but pre-implant performance was poorer for 60 decibels compared to 70 decibels. So he has advocated to bring up the decibel level from 70 to 60 as the candidacy criteria for the cochlear implant program. This is the candidacy criteria which was proposed recently, and this is the revised criteria which was proposed almost 5 years back, and this is initial candidacy where 90 is the upper limit, and then it changed to 70, and now it has almost reached to 60. So what I mean to tell you is the hearing criteria for hearing loss in decibel sound pressure level is changing day by day, or is changing with the technology of the cochlear implants, is changing with the time, with the times. So the level of SPL, decibel level, hearing level required for the cochlear implant program may change in future also. So 70 decibel sound pressure level as the presentation level for determining implant candidacy is a disadvantage, because it is not representative of average conventional levels in the real world, as I told you, and artificially inflate speech recognition performance and disqualify an individual from candidacy otherwise benefited. So for the undergraduate sake, SPL is the ratio of absolute and sound pressure and difference level, and so the 70 decibel SPL, Pearson has requested or proposed the idea that 60 decibel pressure should be taken as a criteria for determining the candidacy for the cochlear implant program. The criteria for speech recognition score recommended a test battery of both pre and post implant assessment. This is too academic, and I'll go through very fast. This is the as-bio sentences, Bamford-Covell bench sentences, and CNC, that is consonant nucleus consonant test, and implant manufacturer criteria are advanced bionics 50% in best aided condition, Cochlear Americas 50% correct in the ear to be implanted and up to 60% in the best aided condition, medal hint is nothing but hearing in noise test, sentence recognition up to 40% correct in the best aided condition. Coming to pediatric candidacy, between the ages to 12 and 24 months, that is 1 to 2 years, bilateral profound sensory neural hearing loss, bilateral profound sensory neural hearing loss. During the hearing aid trial, children should be making at least month to month auditory speech language developmental progress at least for 3 months. They must be observed after fitting the hearing aid for 3 months, and month to month progress should be observed before determining their candidacy. And current behavioral and objective measures serve as audiological checks and balances. The audiological checks and balances will be dealt by the Dr. Shivaprasad in the evening session. And there is an interesting article written by Kilne et al., that is cochlear implant children between 12 to 36 months, that is 1 to 1.5 year, outperformed those done between 37 to 60 months. So the criteria, candidacy criteria, when we were students, the criteria was different. When today's criteria is different, which I'll be going to deal to tell you in subsequent slides. But the idea of Kilney is earlier the cochlear implantation done, the better will be the results. That many studies have proved that. Pediatric candidacy 2 years and above, bilateral severe to profound hearing loss, severe to profound sensorineural hearing loss, no benefit from hearing aid, and 12 to 30% correct in the best aided condition. The test battery, the most of the cochlear implant manufacturer recommend are ITMAS and multisyllabic lexical neighborhood test and PBK test, then hint sentences for children, that is hearing in noise test, that is in children. Who is not a candidate? This is very important question. And medically unfit, various conditions like which make the child medically unfit for the surgery, and which the disabilities which will affect the post implant programs. So those type of medically unfit cases must be excluded from the candidacy. Unrealistic expectations, this is very important in our setup because of the very meager resources and the huge problem. So the hype created by the cochlear implant and then the cochlear implant program, and for this reason the counseling must be done, pre-implant counseling must be done in a realistic manner, and explaining the parents and the other caregivers of the child the real expectations are the what you will get out of cochlear implant very clearly to reduce the unrealistic expectations. And the lesions of acoustic nerve and central auditory pathway, it is a clear-cut contraindication for the cochlear implant, and any active medullary infections, absence of cochlear development, tympanic membrane perforation and medullary disease which is active is contraindication for the candidacy. Now this is the gist of what I have told you, and if the decibel loss is between 10 to 50, do not consider for cochlear implant in all the frequencies. If the loss is in all the frequencies, both low and high frequencies, but the loss is in high frequency with 70 to 120, that is severe to profound hearing loss, and particularly in high frequency areas, consider for an implant. And any value between the both, like in high frequency hearing loss between 60 to 80, consider for implant assessment, reassess the case. And this is an important slide, and where it describes the trends in candidacy, how the candidacy criteria is changing day by day or year by year. The recent advances in cochlear implant technology and the recent advances in information technology and recent advances in biotechnology, and of course the recent surgical techniques, and including the endoscopic insertion of the cochlear implant, all these made a candidacy criteria shift towards a better criteria day by day, and every day, every year the candidacy criteria will keep on changing. So in 1985 the age of implantation advised was adults age 18 or older, and now it is anybody, children age 12 months plus, anyone who is above 1 year. And in onset of hearing loss, the only postlingual was advised in 1985, keeping the neuroplasticity in mind, and in 1990 that was changed to postlingual adults and pre and postlingual children. In 1998 again it was changed to pre-postlingual adults and children, anybody who is pre and postlingual adults and children in 1998. But today pre and post adults and children, the same criteria, anybody. The prelingual, postlingual criteria has gone. Degree of sensorineural hearing loss, profound, as you can see, severe to profound in adults and children above 2 years, and profound in children less than 2 years. Why this profound in less than 2 years children is, there are some studies which proved that if we found severe hearing loss in children, sometimes neonates will improve from severe to the moderate, and very rarely, though rarely, there are some studies. So some criteria changes are going on in this category, and in certain studies they proved that in cases of meningitis, Now, if the cochlear implantation is done early, the results will be better in those children. So, the many studies are going on in this category of the age candidacy. Adult speech codes, 50% sentences quite in a year to be implanted and 60% in contralateral biannually, and pediatric speech codes, lack of auditory progress and 30% or less on pediatric word tests. So, the recent advances in audiological assessment and the recent advances in audiological tests helped us to revise the candidacy criteria, and they also helped many changes have been there in audiometric tests regarding the behavioral audiometry, which help us to assess the children in a better way when compared to way back in 1985. So, the candidacy has been changing, and in future it may change also. Now, coming to India, Cochlear Implant Group of India, which is headed by Dr. Milind Kirtane. In 2011, that was the recent publication of Cochlear Implant Group of India, as far as I know, and they have advised, see the point number 2 and point number 3. Adults and children of all ages can be referred for assessment, that is for cochlear implant assessment, and each case will be considered for an individual basis. This is an important point. Any adult or child can be referred for the cochlear implant program. Each case will be considered on an individual basis, as Dr. Karthik told in earlier, the syndromic child, and which I will be dealing in the next slides, and those cases can also be considered. And patient must have severe to profound hearing loss, which cannot be helped by adequately by the hearing aids. These two criteria help us to do cochlear implant on anybody. So, the still candidacy criteria is changing, and our Cochlear Implant Group of India suggested, as I told you, any person, adult or children, can be taken up for assessment, and patient must have severe to profound hearing loss. The only criteria the Cochlear Implant Group stressed is severe to profound hearing loss. Now, coming to the expanded indications, unilateral deafness, and et al. Has published an interesting article with 11 patients of unilateral deafness, which have not, the hearing aids were not useful, and then even stapedectomy was not useful, mixed conductive hearing, mixed hearing losses. In those cases also, unilateral deafness also. The and et al. Published that in 11 cases they found good improvement with the cochlear implant. So, in future, if unilateral deafness is seen, then cochlear implant candidate, he can be considered as cochlear implant candidate also. Tinnitus resulting from sudden unilateral deafness, that is the debilitating tinnitus resulting from sudden unilateral deafness. Klinjung et al. Published an article which they implanted in a patient, almost 50 to 60 years age group patient with debilitating tinnitus resulting from sudden unilateral hearing loss. They tried intratympanic steroids, then they tried cochlear window membrane change, and then replacing the cochlear round window membrane also, changing of round window membrane also, they failed. But when they tried cochlear implant, the tinnitus was 100% cured. This led to the hypothesis that cochlear implant can be considered for tinnitus, debilitating tinnitus, when all the other measures fail, and which results from tinnitus, which results from sudden unilateral deafness. So, this can be considered for in future candidacy for as a candidate for the cochlear implant program. Now, Dr. Karthik has told in his earlier presentation that a lot of genetic disorders are associated with hearing loss. Now, these are the some of the genetic conditions which we can consider for cochlear implant candidacy, and still the trials are going on, still more data is required to establish the cochlear implant candidacy criteria in these genetic hearing loss cases. And out of the genetic hearing loss cases, as Dr. Karthik told, connexin 26 mutation is the most common, which is seen where the 50%, around 50 to 60% cases of children of sensory neural hearing loss are born with connexin 26 mutation. They can benefit with the cochlear implantation, again provided there is no medically unfit condition, and full cooperation from the family and from the patient is required to be implemented or to implement cochlear implant program in these syndromic children. In Usher syndrome, as Dr. Karthik told, and it is associated with retinitis pigmentosa, and you have to coordinate with the ophthalmologist, and then to rule out the in cases of retinitis pigmentosa, you have to identify the child and ask him to get the evaluation by the audiologist, and it should be the child must be evaluated by a speech pathologist, and all the neurological conditions and associated cardiac conditions should be ruled out, and if he is medically fit, we can consider the candidate for the cochlear implant program. Vandenberg syndrome, where you can see heterochromia iridis, that is one iris is one color and another iris is another color. As you can see in this picture, the picture cutter is Naveen Panchola. That picture is taken by Dr. Naveen Panchola, and Andre and Shapio et al. In their article have described that in Vandenberg patients also one can try candidacy, cochlear implant program. Jervell-Lang-Nielsen syndrome, where you can see the arrhythmias, cardiac arrhythmias, if the child is otherwise fit for the surgery, otherwise willing to participate in the cochlear implant program, he can be the child can be considered for cochlear implantation. And another significant recent research is going on mitochondrial disorders, not only in otology, in various specialities including diabetes. Lot of studies are being published on the mitochondrial disorders, at the cellular level, what are the changes are seen when the disease and non-disease cases. So in mitochondrial disorders, sensory neural loss is seen in 40 to 70% of the patient. Again, there are two categories of mitochondrial disorders, syndromic and the non-syndromic. Out of the syndromic category, it is the MELAS, that is encephalopathy, lactic acidosis, and the stroke-like episodes, maternally inherited diabetes and deafness. There are a lot of research is going on in this category, where the maternally inherited diabetes and deafness is considered to be a genetically inherited autosomal recessive kind of diabetes causing leading to diabetes, genetic cause of the diabetes. Now in these type of cases, cochlear implant will really help them, because most of them are born with the sensory neural hearing loss, and when there are no other contraindications, the cochlear implant can be considered. In Kearns-Sayre syndrome, where the sudden syncopes and cardiac, cerebellar ataxia and sudden cardiac syncopes are seen, when the child is otherwise fit, they can be considered for cochlear implant program. But the caution is, the pre and post implant procedure is equally exhaustive, like cochlear, compared to cochlear implant surgery. So whenever a syndromic child is considered for cochlear implant program, we have to counsel, and we have to see that the condition of the child is fit for both pre and post cochlear implant procedures. Chronic progressive external ophthalmoplegia, this can be considered for the cochlear implant if the child is considered to be fit. Mitochondrial disorders, the ototoxicity of aminoglycosides is hypothesized to the mitochondrial DNA mutation, that is, this is the A1555G mutation. So this can cause ototoxicity of aminoglycoside. In those cases, you can consider for cochlear implants. Neural plasticity, the best results in children implanted under 2 years, as I told you, the Pearson et al. And the Andre Sampio et al. Have suggested that best results are seen in children implanted under 2 years of age. So when their neural plasticity is very in a nascent stage, and after 6 years, as we all know, the speech language development almost halts after 6 years of the age. So before 2 years, if we do cochlear implant, the neural plasticity will be better. In adults with behavioral input, in adults, when there is a behavioral input from the external environment, a good behavioral input will help them when we do cochlear implants early in them with the good behavioral input like speech language or the sign languages, this type of input, if you go on giving them in a better way, in adults also, if cochlear implant is done in early ages, then it will be beneficial. Auditory neuropathy and dyssynchrony. As Dr. Karthik has told, he has dealt with the auditory neuropathy. It is a complex and multifactorial with spectrum of syndromes. And 10 to 14% in children are severe to profound hearing loss. Cochlear implant in these cases, auditory neuropathy, will only help when there is no cochlear nerve deficiency. This thing must be ruled out before considering them as the candidate for the cochlear implant program. Cochlear nerve deficiency. Coming to future directions, where we are going. Bilateral implants, though it is costly, in some studies they found that they are useful, in some studies they found that they are not useful because of the technical reasons. The speech processors are interfering among themselves, and then the technical issues like speech processors may not be good for the bilateral implants. But in some studies they found that bilateral implants are useful, and a recent addition to the armamentarium is hybrid and EAS, that is electroacoustic stimulation cochlear implant. These are the hybrid. These are the combination of conventional hearing aid with the cochlear implant. Totally implantable cochlear implants are another major advance in the field of cochlear implants. Bilateral cochlear implants advantages are improved localization. As we all know, if the patient is having bilateral hearing loss, if you give hearing aid for 1 year, one year only, then he cannot localize the sound from behind, or he cannot localize the sound from anywhere properly. So that problem can be solved with the cochlear implant program, and improved speech in noise performance. That is the most important thing. In one of the study they found that if you do bilateral cochlear implant, they can enjoy the music more compared to the unilateral cochlear implant patient, and it improves the quality of life, and it improves the acceptance by the cochlear implantee. The major research is going on in the area of hybrid and EAS, that is electric acoustic stimulation, combination of cochlear implant and hearing aid. High frequency, that is shorter electrode array, is for high frequency, and then low frequency hearing loss can be cured with typically mild to moderate hearing loss can be cured with the conventional type of hearing aid. As you can see here, these are the hybrid variety, that is electroacoustic stimulation, electric acoustic stimulation. Still in clinical trials in US, approved in Europe. They have done extensive studies in Europe, and patients monosyllabic, the criteria for the hybrid EAS is patients monosyllabic score. That is, earlier disyllabic word tests are used to find out the candidacy of the cochlear implantee, but now shift is towards the monosyllabic score. Like if you see bat and ball, now monosyllabic bat. If the patient can hear less than or equal to 60% at 65 decibels pressure in the best aided condition, he can be considered for hybrid EAS score. European and trial data, better with EAS than cochlear implant alone or hearing aid alone. European trial data has shown that the hybrid variety is better than single cochlear implant or the single hearing aid. Noted especially in music and speech in the noise. And the only point which is worrisome for the surgeons is the risk of damage to residual hearing. So because when we do cochleostomy, we will be removing the residual hearing in the patient. That can be, research is going on how to preserve the residual hearing acuity. EAS audiometry, within the range of normal, up to 60 decibels to up to 750 Hz. This is the criteria for the hybrid candidacy, and no better than 70 decibels in 1500 Hz and above. This is the entire this area, the colored area is the candidacy for the hybrid and EAS. Criteria overlap with hearing aids and middle ear implants, and it is currently unclear what is the best treatment option is, but keeping the resources and the conditions in India, still a lot has to be done in this area, and still hearing aids are cheaper compared to cochlear implant. So keeping in view of the resources here with us, this may take a long time before we advocate cochlear implant or the hybrid cochlear implant or a hybrid hearing aid into our system. This is the gist of what I have told you. Middle ear implants, when the hearing loss is 30 to almost 60, consider in low frequencies, consider middle ear implants, and in high frequencies, consider bone conduction implants, and similarly the cochlear implants can be considered for profound hearing loss both in high and low frequencies. And the advantage of hybrid is it preserves the low frequency resolution and then it restores high frequency sensitivity. This is the advantage of hybrid electroacoustic stimulation device. Now, totally implantable cochlear implant with the technology, the biotechnology developing with the leaps and bounds. So there are major changes in implant technology where internal components and external hardware, in all areas the changes are going on, and the internal components, rechargeable batteries are being invented with microphone subcutaneously implanted. Speech processor is also implanted, and external hardware, battery recharged, on and off, volume, sensitivity. So these things are going on in biotechnology, and the totally implantable cochlear implant looks like this. And as I told you, implantable rechargeable battery and audio pre-processing, stimulator mode, speech processor, everything will be implanted. High performance implantable microphone that will last a lifetime, and in future it will be integrated with the cell phone, with the TV, and mini microphone also. So a lot of changes are going on in technology. So in future the cochlear implant technology will see a sea change with the help of biotechnology. Totally implantable cochlear implants advantages are there will be no external parts, able to hear, able to hide the deafness because there won't be any visible hearing aids. No cables, able to hear 24 hours, and disadvantages are larger internal device, larger insertion, technically difficult to insert, and battery will have to be replaced approximately for every 6 years. And here the body noises, that is breathing and swallowing. When the totally implantable cochlear implant is implanted, one can hear the internal noises like breathing and swallowing also. That is the worrisome, and the post-implant audiological programming is trying to take care of this problem. TK results: 3 patients implanted in Melbourne, able to have invisible hearing or use 3G processor and external sound processor. And hearing acuity, they observed significant changes in hearing acuity and speech discrimination, where they found that 3G hearing is almost within normal limits, and in speech discrimination 77 improvement is there. So lot of changes are being expected in the cochlear implant program in future worldwide. And in summary, 7% are born with hearing disability. So it is very important to understand the candidacy of cochlear implant program and then implement the program for the benefit of the young children and the adults who miss the beauty of the world. Candidacy: severe to profound sensorineural hearing loss, limited benefit from the hearing aids, no medical contraindications. Expanded indications are unilateral deafness, tinnitus resulting from sudden unilateral deafness, and genetic hearing loss. Future directions are, as I told you, bilateral cochlear implants, hybrid implants, and totally implantable cochlear implants. So these are the future directions where we are leading into. Thank you very much. That is the place where I come, ESI Hospital Nacharam, and we are happy to swap this hospital with the Nacharam to allow the medical college to be functioning here. So that is ESI Hospital Nacharam, and that is the place I Any questions? Any questions?
Hello.
Sir.
Hello.
Sir.
Good morning, all of you. A wonderful presentation, Dr. Len.
Thank you.
He was mentioning about medical fitness of the patient to be implanted. Interestingly, last year we had a patient presented with one lung, actually. He had a pneumonectomy done, and he's a 58-year-old working individual from Saudi Arabia, and with a bilateral deafness, profound deafness. And we started doing under local anesthesia like any mastoid surgery.
Oh.
So we did, interestingly, 5 cases last year under local anesthesia. When he mentioned about medical fitness,
Yes, sir.
just,
Yes, sir. Yes, sir.
so that's the interesting aspect. Last year we had postlingual adults.
Yes, sir.
And when you are doing after putting the electrode array, and you are doing NRT, they started saying, I'm hearing. That's another interesting. Like
Yes,
when we do stapes surgery or when we do osteoplasty, when you test the hair, immediately he responds. In the same way, when NRT is being done, and yeah. So that was the exciting part of our implant program. Last year we did 5 cases. So yes, certainly it's very important fitness,
Yes,
as he said.
Yes, sir.
If they have cardiac issues and other major issues, we can't. But there is another way of helping them under local anesthesia.
Yes.
Thank you very much. It's a
Thank
wonderful
you, sir.
presentation.
Thank you, sir. He's asking. Sir.
Thank you, Lenin,
Sir.
for your excellent presentation.
Sir.
How to detect the deaf as early as possible so that you can select the right candidate for cochlear implantation surgery.
Sir, as Dr. Karthik told, sir, the behavioral audiometry, it is a technical term, behavioral audiometry, meant for the audiologist and the otologist. The best judge are the parents, sir. When they suspect anything, or the pediatrician is also best judge, sir. When the developmental milestones are delayed, and the developmental milestones also include the auditory testing, sir, like turning the head towards the sound and localization of the sound. These things, when the pediatrician assessment is assesses at their clinic when the child goes for vaccination. So this must be done by the pediatrician and the parents, sir. So whenever they suspect hearing loss.
So we should have awareness programs for the
yes, sir.
parents,
yes, sir.
and for the pediatricians.
Yes, sir.
So that we can detect early and go for implant early.
Early suspicion and the diagnosis is important in cochlear implant program, sir. And another session is going on, will be taken by Shivaprasad Bodupalli, and he will be dealing with newborn hearing screening, sir. And that is the thing which the AOA also should also recommend the government to include the newborn hearing screen, compulsory newborn hearing screen, like vaccination, sir. The otoacoustic emission to rule out the outer hair cell disability. So that also helps that screening also helps in identifying the congenitally deaf children, sir.
Good afternoon, sir. Sir.
Yeah.
Sir, you have said that the recent advancements the boundaries of recent advances are being pushed. So
I'm not able to.
The boundaries of recent advances are being. The boundaries of recent advancements are being pushed, sir, in technological point of view. But the child is losing many words each day.
Can you speak
the boundaries are being pushed many.
Excuse me. Can you speak without mic?
The child is losing many words each day, right, sir? The child is losing many words each day. That's why the child we are recommending as low as the possible age. 12 months is the right age. Are we pushing those boundaries any lesser?
You want to bring down
Yes.
The question was, he has asked, the candidacy criteria was revised from the 12 months. That is, the recent candidacy criteria is 12 months and above. Why it can't be reduced down? So as I told you in the lecture, there are chances in certain studies, they proved that there are chances when a child is born or diagnosed with profound hearing loss, there is a chance for the improvement in their hearing ability. That's why they recommended waiting for 12 months. But in cases of meningitis, when ossification is there, when there are no chances for improvement, then one can consider cochlear implantation surgery. But with the recent advances and the as told by Karthik, the syndromic children, and the Dr. Vishnuvardhan Reddy, distinguished surgeon. So surgeons like him will be going on experimenting with the cochlear implants, and the new criteria may come out. And with the biotechnology improvements, in future the congenital deafness can be considered right from the birth or till the anesthetic complication, when the child is fit for anesthesia complication. If Dr. Kalyani gives go ahead with the cochlear implant surgery, then we may consider, or we may revise less than 12 months also. The day will come, or may not come also, because some of the studies have found that the behavioral audiometry, doing the behavioral audiometry and the identifying the or programming the cochlear implant after the surgery is difficult if it is in the infancy period. That's why maybe they did not include the criteria less than 12 months right now. But in future, with the improvements in biotechnology and with the improvements of surgical techniques, probably the criteria may be revised and they can be added. Thank you very much.
Thank you, sir. I now request Dr. Yugender sir and Dr. Vijay Praveen sir to please come and felicitate Dr. Lennon. I now invite Dr. Sunita Linga Reddy. She is the Managing Director and the Chief Radiologist at Lucid Diagnostics.
Thank you for the introduction, and a very good morning to everyone. Please do excuse me. I think I'm speaking amongst ENT surgeons with a bad throat, but I hope it's pretty audible. So I've pertained my imaging before the cochlear implantation. So I don't have to explain this. We do have two types of hearing loss, conductive and sensory neural. So we'll be looking at anatomy and then we move to the pathology. So mainly I'll be covering the cochleovestibular anomalies, which are the most commonly encountered when I get a CT or an MRI for or before the cochlear implants. So we'll look at all those conditions, what are the imaging features. So you could have cochlear anomalies, and we also have vestibular and semicircular canal anomalies along with the cochlear abnormalities. Causes for luminal obstruction, main cause that we encounter is the labyrinthitis ossificans, which can be because of multiple causes, meningogenic, tympanogenic, hematogenic, and of course trauma in some cases where the patients come a little later and there is a history of trauma, so we need to check whether the lucent or the fracture line is coursing through the cochlea, and then the surgeon can choose the other ear for the cochlear implants. Metabolic causes, of course, like otosclerosis. So internal auditory canal, we encounter the most common tumor that we encounter is acoustic schwannoma, followed by meningioma, and of course in children, cochlear nerve anomalies. So other causes are important not as contraindications, but I think it helps the surgeon whenever there is an aberrant internal carotid artery, or a high riding or a dehiscent jugular bulb. Sometimes we see sigmoid sinuses which are asymmetric on both sides. So this probably helps during the drilling when you think that there is lesser amount of the bone on one side compared to the other side. Facial nerve course, just to check if there is an aberrant course so that you don't touch the nerve during surgery. Mastoid and the middle ear for infection. I think one of the previous speakers mentioned that you have to look for middle ear disease. Of course, you have to treat it, I guess, before you go ahead with a cochlear implant or you choose the opposite ear. So these are the things that has to be mentioned by the radiologist when we get for imaging. So what is the role of imaging? We have to rule out any kind of congenital anomalies. Luminous, of course, I think is the most important thing, because you coil the cochlear implant into the turns of the cochlea. So the 2.5 turns of the cochlea. So we usually now give an image depicting the entire cochlea and any abnormalities that may affect the surgical procedure. Of course, we do have absolute and relative contraindications for cochlear implant surgery. Absolute is absence of the cochlear nerve, but I was just talking to Dr. Vishnuvardhan Reddy, and he was saying that they're doing now brainstem implants when there is cochlear nerve aplasia. So I guess it helps to know before surgery, so you don't go ahead with the implant and you stick to another mode of treatment. Relative contraindications, I think a previous speaker was mentioning about the perilymph pressure. This is very important in cochlear anomalies like Mondini's. I've also seen one of the surgeries being performed by the ENT surgeon when it is rushing out with lot of pressure, and I think it pulls out or pushes out the implant. So this is very important for us to mention on imaging. And of course, labyrinthitis ossificans, when there is ossification of the cochlea, I'm sure the cochlear implant cannot go through the lumen. So CT versus MR, of course, I think there is definitely an improvement in surgeons writing MRI, but I still see so many times that they just suffice with the CT temporal bone and do not ask for an MRI inner ear and cochlea. So since I have quite a few budding ENT surgeons and the senior surgeons in the audience, yes, it is a request, but because I've seen a patient where a cochlear implant was done, but I think unfortunately only CT was done at that time, and the child wanted to have another implant in the other ear, and we were not able to do the MR subsequently because of the implant, and you know that it's a contraindication to do the MRI in a patient with cochlear implant, and there was labyrinthitis ossificans. The surgeon went ahead with the double implant on the other ear, but was not able to coil. It was very disappointing because I had an association with the child and the family. Child was very disappointed that the surgery was not done. So I just felt as a radiologist, if at the initially we would have done an MRI. Why MRI is useful, I would show it to you in the later slides. We pick up membranous labyrinthitis on MRI, which cannot be picked up on CT. Only when it ossifies we can see on CT. Even any radiologist cannot pick up membranous labyrinthitis on CT. So whenever there is a clinical suspicion of labyrinthitis, or whenever you're planning for a cochlear implant, please do advise CT temporal bone as well as an MRI inner ear and cochlea, just to be doubly sure. Even for the surgeon it helps, because you want to plan for the other ear. We can always rule out the other abnormalities or the minor abnormalities, some of them which cannot be picked up on CT. So CT, of course, is the first and initial modality for cochlear implant imaging. Now, of course, we have multi-slice, 64, 128. 128 nowadays, some of the companies promote as 500 slice. But I think after a point, after 64, what you see is the same. For me, as a radiologist, I don't think it really helps me in the diagnosis, but of course it's always better to have better resolution when you're reporting. And we have post-processing, which you'll be seeing in the images. MRI, of course, we have a very good sequence, which is called by different names on different machines. It's called as a 3D Fiesta, but as long as the surgeon writes MRI inner ear, any radiologist would do this sequence, and we do reconstruct the cochlea on MR also. Advantages, of course, CT, you can get the entire bony detail. Facial nerve can be seen in the entire extent. You look at the middle ear disease, and you can also look at the mastoid pneumatization, which I'm sure as surgeons you know the importance. So disadvantages, ionizing radiation, not just for temporal bone, any kind of CT that you do in any, whether it's a child or an adult, that's of course a disadvantage. And the greatest disadvantage, I think, for the ENT community would be not able to visualize the cochlear nerve, which will be just seen in only one section, but not the entire course. So MRI, as I've told you, of course, vestibulocochlear nerve can be traced entirely, and we can tell you with 100% precision that the nerve is present or it's hypoplastic. There is no radiation risk, and it also provides detailed information about the labyrinth, which I mentioned. Disadvantages, of course, we cannot look at the middle ear because it's air-filled, and you know air cannot be depicted well on the MR, so mastoid also cannot be well visualized unless there is disease in the mastoid. Then we see a different signal in MR where it's called as acute mastoiditis. And in children, of course, now with the latest MR, now we have a 3T, we do run a sequence which is for 5 minutes, but sometimes it's very difficult to make the child lie down without movement, because movement will hinder the complete study. We cannot do an MR, so we have to sedate or anesthetize the patient before we do the MR study. And resolution, definitely, because we are getting sub-millimeter thickness on CT. It's not possible on MR to get a sub-millimeter. I would not say not possible. We could plan a sequence, we could do it, but the quality falls whenever we cut the sections thinner on an MRI compared to a CT. So just very few slides on only the inner ear structures on the anatomy. They're all marked with the red, so these are the axial sections on the CT. So you can see the turns of the cochlea very well. That's the apical turn, part of the middle turn, and here what is marked is the basal turn. And the coronal section, you see the apical, middle, and the basal turns of the cochlea. So this is what I told you, when we do the post-processing, we get all the turns of the cochlea. So any kind of cochlear abnormalities, you can see whether there is any underdevelopment of the cochlea. The facial nerve, as I've mentioned to you, you can get all the entire length of the facial nerve can be traced on the latest CTs. So you see the internal auditory or the meatal segment of the facial nerve. That's your anterior geno. Then you see the tympanic segment. You see the posterior geno, and then the labyrinthine, the mastoid segment before it exits through the stylomastoid foramen. Vestibule, of course, very simple for you to look at. You can look at the vestibule, and of course that's the coronal section showing the vestibule. Oh, that is full screen. No, that's a full slide. Okay, I'll adjust. Okay. So we move on to the semicircular canals. Before, of course, we were not able to see all the semicircular. Now we can see with the post-processing what are marked is the superior semicircular canal. And then, of course, you have the lateral semicircular canal, that's the coronal sections. So now, of course, there's no difficulty in looking at the semicircular canals. When we used to report on the single and the dual slice CTs, we had to, of course, trace on the axial sections. Now you get the entire semicircular canals on the post-processed images. Unfortunately, I'm not able to run the videos on this. But of course, we can turn the cochlea around. That's the 3D VR of the cochlea. You look at all the turns. Then you have the vestibule. That's the oval window opening. You have the lateral, superior, and the posterior semicircular canals. So MRI, what I mentioned, its basic advantage would be to look at your nerves. So anteriorly, of course, as we all know, anterosuperior is the facial nerve, postero-inferior is the vestibulocochlear nerve. That's your facial and that's your vestibulocochlear nerve. This is the tetrad appearance that we see. Again, we reconstruct. That's a 3D sequence that we acquire. So we get a volume sequence, so you can do a reformat in sagittal, coronal, whichever plane you want, even in obliques. So what you're seeing here is the facial nerve, then you have the vestibular, that's the cochlear nerve, and this is the vestibular before it divides into the superior and the inferior vestibular. So you go on in your sections and you can see the division of the nerves. So now we move on to the pathology. We'll look at some of the congenital and then look at otosclerosis, labyrinthitis, and end it with tumors. So Michel aplasia, not at all common. I think I would have encountered in more than a decade of imaging in temporal bone, probably couple of cases of Michel aplasia where there's complete development of the inner ear, as it constitutes only, almost less than 1% of the congenital malformations. So what you see, you can see complete absence of the inner ear structures on the right side. You have the left for comparison, and you see, of course, there is a cochleovestibular anomaly even on the left with middle ear disease, which is detected obviously because you have two sides. I think temporal bone, that's one of the greatest advantages. Unless you have bilateral anomalies, it's always easy for you to look at the normal and then you can pick up the abnormal on the other side. Common cavity deformity, so you have a confluence of cochlea, vestibule, and the semicircular canals. So what do you see? You just see a ovoid cystic space. We've seen some of the normal slides, so where you see nicely the vestibule, the cochlea, the semicircular canals. In this abnormality, you will just see one oval cystic structure. So you can see both sides. You see only just an oval cystic structure in the place of cochlea, vestibule, and semicircular canals. So moving to hypoplasias, unfortunately I was not able to place an aplasia. So this is just a well-formed cochlea. All the turns are formed, but it's hypoplastic. I'm sure you'll be able to appreciate this, as you can see better on the post-processed and the 3D VRs. This is of course the advantage with the latest improvement in technology. We've seen the normal cochlea where you've seen 2.5. Sorry about that. So you see you saw all the turns of the cochlea in the normal slide. This is obviously, that's the advantages of the newer CTs. You can see that it's well formed. You have the apical turn, you have the middle and the basal turn, but it definitely looks hypoplastic. So this is, I think, the commonest, which was also mentioned by the, I think, the genetic doctor who spoke, the first speaker. So the Montanese is one of the commonly encountered, even in imaging, it's one of the most commonly encountered. Of course, now we are able to differentiate. I don't know whether you use the terminology of partition defect anomalies. So now we do give even on imaging a specific, like we say type 1, then we do a 2A, 2B. But generally, of course, again, the commonest, everybody is more used to the terminology of saying it as Mondini dysplasia or a deformity. So obviously, it constitutes more than half of the inner ear abnormalities. Here, it develops only 1.5 compared to the 2.5 that we've seen in a normal cochlea. So you have a confluence of the apical in the middle. Basal is well formed. We do see other abnormalities with Mondini's. So you see a classic case here. You see the normal basal turn, which looks slightly dilated when compared to the normal. And what you see here, if you remember, you saw two different structures in the normal cochlea. This is fused together, the apical and the middle turns, to form one common cystic structure. So again, for you to see, you can clearly see you saw a nice 2.5 turns of the normal. What do you see here? It's hardly making 1.5 turn on the post-processed images. So this, I think, over the years of imaging, for me also, this is a surprise because I think even surgeons are realizing this is a very important cause of hearing loss over the years. So nowadays, I do get requisitions where clinicians ask to look specifically for a dilated vestibular aqueduct, or it's called as large endolymphatic duct sac syndrome. But a request to the ENT community is, please do ask if at all it's not picked up on CT, I would advise it's better to write a CT and MRI when you want to, or when you have a clinical suspicion of ruling out an endolymphatic duct or a sac syndrome, because unless it's grossly dilated, it may not be picked up on a CT, and we do need an MR. MR depicts the fluid-filled structures, that is your cochlea, your vestibule and semicircular canals, much better than the CT. So what you see here, I think an enlarged vestibule, sorry, that's a skip slide, that should not be here. So this is a large vestibular aqueduct. You can see that it's grossly dilated. Normally, the diameter or the thinness of the vestibular aqueduct should not be more than any of your semicircular canals. So what you see, it's almost like about 5 times the size of your semicircular canal. So just to, as a closure, I think I've just added a few slides on the semicircular canal dysplasias and aplasias, because we don't really encounter these as separate anomalies, but we do see them when they come for cochlear anomalies or before cochlear implant. We can see isolated lateral semicircular canal dysplasias, sometimes with or without an enlarged vestibule. So just a couple of examples. So you see posterior semicircular canal almost absent here. Superior is also almost, instead of calling it dysplastic, I could call it aplastic. So you saw the cochlea before with all the semicircular canals. Here almost complete aplasia of the semicircular canals is seen. So this is a very commonly encountered thing. In fact, this is a question to the ENT community from a radiologist, that is there any clinical significance? Because I encounter quite a few hyperplastic lateral semicircular canals. I always do mention it in the report, but sometimes I wonder whether it is really significant or it's a normal variant, because I think if I take my database of cases and do it, I wouldn't, probably because I do get a lot of dedicated imaging for temporal bone, I am able to see it much more frequently than the other radiologists. But this is actually a question in my mind whether it's clinically significant, or should I not mention it. So what you see is when you compare to the other turns of the cochlea, that is the superior and the posterior, lateral looks hyperplastic. But I do see it in asymptomatic patients also who have no clinical symptom which could be pertaining to it. So this is a sincere doubt from my end. So of course, vestibule dysplasias, definitely there is a history of hearing loss. So what is the difference between a hyperplasia of lateral semicircular canal and LSCC vestibule dysplasia? I've kept a normal slide for you for comparison. That's the amount of bony bar that you should see between your vestibule and your lateral semicircular canal. And what do you see on the other side? You see that the bony bar is shrunken. It's not shrunken, it's just not developed, and it's almost fusing, that is the vestibule and the lateral semicircular canal are almost coalescing together to form a cystic structure. So this is called as lateral semicircular canal vestibule dysplasia, which is also one of the causes of sensorineural hearing loss. Just few other examples of LSCC vestibule dysplasia. This was a case that was present bilaterally. You see almost complete absence of the bone, and vestibule and LSCC have fused together. So that's how you see on the 3D VR images. So moving to the IAC anomalies, why do we need to look at the internal auditory canal as radiologists? The first clue for us, for example, patient comes for a CT and there is no requisition for an MR. Usually when it is narrow, I always advise the clinician to ask, or I advise them to get an MRI done to rule out a cochlear nerve, either hyperplasia or aplasia. Usually whenever there is a narrow canal, less than about 1 to 2 mm in size, it's not necessary that in all cases that I would have asked for an MR that I would have seen a cochlear nerve aplasia, but I think if the surgeon is planning for an implant, it is mandatory that you ask for an MR to rule out cochlear nerve aplasias. Widened, of course, all of us know. CT again is very insensitive when you want to pick up intracanalicular schwannomas. It's a large, obvious IAC schwannoma. Yes, you can pick up, and you need to ask for contrast study, because impossible for us to pick up small schwannomas. That is, of course, I think one of the disadvantages of CT to pick up intracanalicular schwannomas. Be showing a couple of studies, I think, on the MRI. So this is, you see, slightly narrowed internal auditory canals. MRI was done, and you see As I've shown you a clear tetrad appearance there, here there's a complete absence of the cochlea. So you're able to see the facial and also the vestibular nerve. So moving to otosclerosis, this is a topic to itself because I get quite a few requisitions. Now I've started even reporting wise, I grade the otosclerosis because radiologically we have a grading which moves from 1 to 3. 2 is again split into A, B, C. But I guess it helps the surgeon in deciding on the type of implant, the prosthesis that you place before the surgery. So, of course, broadly dividing, you have the fenestral and the retrofenestral. Fenestral, I think I don't have to explain in detail to the ENT community. So, the first, I think the challenging part for a radiologist would be the early cases of otosclerosis for me, not the large chunks of demineralization or hypodensity, which are very obvious on CT. I do get a lot of subtle cases where patients have only complaints of tinnitus and hearing loss, and whenever I don't find anything on CT, I definitely put a lot more attention and try to look at the region of fistula antifenestrum. And another important thing I actually realized as a radiologist is the thickening of the foot plate, which is very, very subtle for us on imaging because it's just a thin linear area. So, but I think over the years when you keep reading temporal bones, yes, you do get the perception when it is thickened. And I think it does help the surgeon in the early cases when they're able to pick up early cases of fenestral otosclerosis where there is only mild thickening or mild hypodensity in the region of foot plate. This for presentations I usually place the obvious ones. You see a large chunk of demineralization or hypodensity. So that's one of the classic sites where it's also encroaching into the region of oval window. So of course we do mention whether it's going into the foot plate, whether it's encasing the anterior crust and is also extending and encasing the posterior crust of stapes. So this is another case where there is fenestral and retrofenestral, just for you to see it more clearly. It's also encasing around your basal turn of the cochlea. So inflammatory, of course, labyrinthitis, this I'll spend a minute on this. As you all know, it is an inflammatory disease of the membranous labyrinth, and you have various causes which you're all very much aware of. So coming to imaging, as I've mentioned earlier, it can be missed on CT because sometimes especially the membranous stages, it can be picked only on the MRI. So this is what I mean. So you have a normal for comparison on the left. Usually fluid will be hyper, it's called as hyper in our terminology. What you can see is it's white. So when you see the right side, completely the right white is filled with intermediate signal intensity or hypointensity. It's not only present, it's extending into your cochlea, vestibule and semicircular canals. We don't usually do a contrast study, but I think that this particular patient came with an MRI inner ear with contrast. Maybe the surgeon had a suspicion of even an IAC schwannoma is what I assumed. But even in cases of labyrinthitis, you do have contrast enhancement, which is of course very much different from what you see as a tumor. So you see enhancement, so not only into the vestibule, but also even into the cochlea, you see enhancement on the post-contrast study. So these are classic cases on the CT, which I've told you. So this, you're not seeing the turns of the cochlea because it's replaced by bone. So that's why it's called as labyrinthitis ossificans. So post-processed images, you have a normal for comparison, right? You see the entire basal turn is ossified because of labyrinthitis. So of course, another case where you see involvement of also the semicircular canals, and of course we do mention the other abnormalities when the patient comes for reporting for temporal bones. So tumors, commonest acoustic schwannomas. Signal, I'm not going into that because it's not an audience of radiologists. So you see a large tumor in the left internal auditory canal. It's extending into your IAC. It's also a CP angle tumor. This is not like a radiological dilemma for any radiologist. It's an obvious pickup. And the commonest diagnosis that we would give would be an acoustic schwannoma. Important ones would be cases like this, where you have tiny lesions as it's marked here. That's a very tiny intracanalicular schwannoma. So these can be missed on CT. So whenever there is a clinical suspicion of tumor and labyrinthitis, please do ask for an MR. And of course, you also need to ask for a contrast study when you're suspecting an intracanalicular schwannoma. Meningiomas is the second differential for us as radiologists. Of course, we do have some classic imaging features which differentiate, and we will also be able to separate the vestibulocochlear nerve from the meningioma, because as you know, meningiomas arise from the meninges, whereas schwannoma is arising from your acoustic nerve. So trauma, just for conclusion, I've added trauma. So this is what is the role of imaging. Of course, is just to show you that it is traversing through the cochlea, so it may help that if at all an adult patient is coming for you, we get a lot of requisitions, even patients who are aged 20 years who come for cochlear implants. So if there is a history of trauma, yes, it helps, because if there is a fracture line traversing through the cochlea, I'm sure the surgeon would prefer to put the implant in the other ear. So in conclusion, I think imaging plays a very important role. In fact, I think the doctor left who spoke on genetics. So I had a question that don't you ask for imaging when you pick up a genetic disorder? Because he said you do imaging, but it is not. I somehow felt that he didn't think that imaging played a role in genetic disorders of inner ear. I guess since everybody, all who are left as ENT surgeons, I think the ultimate role is to help in restoring the hearing to the child. So I think imaging, doctors mentioned that imaging is an important role. But I've seen over the years that I think it goes hand in hand. Since I specialize in head and neck and temporal bone, I have a wonderful association with the ENT surgeons. I would actually call them the best, because they interact with me on a regular basis, which also helps me because they stretch me to the limits. And I have one particular surgeon who keeps asking me all kinds of questions even after so many years. But it does help me to become a better radiologist, because obviously at the end of the day, I think an ENT surgeon or a radiologist, it's to help the patient to get the best possible hearing in cases of implant, or to restore hearing, whether it's conductive or sensory neural. So definitely there are varied causes for sensory neural hearing loss. And as I've mentioned in the talk, even in imaging, CT and MR go hand in hand. But of course, in India, I think one of the most important things is it has to be cost effective. So I think when patients come from all walks of life, you would want to advise a CT first, because it's a lower cost. But when necessary, it is a request to the ENT community that please do ask for an MRI when you have a clinical suspicion, especially for the indications that I have mentioned. So HRCT, as I've said, is the mainstay. But MR is definitely superior when you want to rule out membranous stage of labyrinthitis, when you want to look at cochlear nerves, that is, you want to rule out aplasias before implantation, vestibular aqueduct, that is the enlarged endolymphatic duct sac or duct syndromes, and last but not least, the intracanalicular schwannomas that I have shown you. So of course, CT definitely now, for me, I think in 80% of the cases, I would be able to give a decent and a helpful report to the ENT surgeon. Because of the evolution of imaging technology, we are able to do everything possible on a CT except for those niche conditions that I have mentioned. So I think as long as the surgeons are aware where to write, an MR CT would suffice, but in that 20% of the patients, it would help. But for cochlear implants, which was, I think, my previous talk, definitely CT and MR have to go hand in hand, because we cannot take a chance before the implant. So CT and MR are must for implant, before implant. But sensory neural hearing loss, I think it's the discretion of the ENT surgeon to take a call. First line of imaging should be an HRCT, and if there is a clinical suspicion, then move on to MRI, depending, of course, on the patient's status of spending the money. So thank you all for a patient hearing, and of course welcome any questions for me to become wiser also.
Hello ma'am. It's an excellent lecture ma'am, and I have learned so many things from the slides. Actually it's not a question. I want to know what is the difference between FRMI, that is functional MRI, and the MRI.
Okay.
Because in syndromic children, mostly it is the fMRI, that is functional MRI, which is going to help them more than the
Functional MRI would be excited if the ENT surgeon starts sending me functional MRI for hearing. We normally do functional MRI for neurological patients. We get requisition for tumors. So especially when it is involving the premotor or the motor cortex, surgeon would want to know how much he can encroach upon to the tumor. So we do have paradigms. Of course, none of us purchase the actual paradigms. It's a little separate software that we have for functional MRI, but motor, visual, auditory, we can perform. So what we do is we do finger tapping because it's a motor task by any one of us, and it elicits a signal in the brain, so which is nothing but functional MRI. So you're asking the patient to do a motor task, and you're looking at the premotor, the motor, and the supplementary motor areas which are activated. So we give information to the surgeon whether the tumor is close to the premotor, motor, it involves, or the supplementary. Visual is the same. We try to tell them to speak, like do sounds, and then we look at the vernix and the Broca's.
The reason I asked is, can we club with the hearing?
Is a question because the patient can't hear, right?
Actually, it is like this, ma'am. I think you need anesthesia for the MRI for a small child. So when the sound is stimulated, so it has been theoretically proven that even the child can hear without, in the sleep, while sleeping also, sound can be transmitted through the ear through the some kind of speech processor. Now that signal will be picked up by the auditory nerve, and that goes to the auditory brainstem. Then auditory pathway. This is the full cycle. That is the afferent pathway. So the functionality of afferent pathway, intact afferent pathway, is the basic criteria for determining the candidacy of the cochlear implant. Can the functional MRI helps?
First, I would require a paradigm for auditory stimulation, which unfortunately I would not be able to do unless it is like a third-party vendor that we would have to purchase. But I don't think it's being done as a routine practice. So even companies don't really, advocate that. As of now, since what we can do is we only do the motor, the visual, and the speech. Visual is we can do cards. So visual stimulation is done that we write on cards and we do the visual stimulation. But unfortunately, we would not be able to stimulate this unless we have the particular stimulator, which is again MR compatible. So which has to be bought separately by us. So we don't really go to that extent of doing fMRI.
This is a just doubt, ma'am.
No, absolutely. So I think
this
has to be pushed from the ENT community so that I think centers will probably, or radiologists would start doing, and then we can also ask the companies when we pick up the MRI. The limitation, of course, is it has to be MR compatible. Since you've asked me that, my question would be, are you going to get MR compatible cochlear implants in the future?
In future, they are trying to do it, ma'am.
Yeah, and I think that is a request that you should all push hard.
Yes.
Because especially when I had this child, it was a little disheartening because, children get disappointed, and then we could have done an MRI in that case, and then we could have said, this child is not fit for, a double implant in the other ear.
They are trying in totally implantable cochlear implants.
Oh.
With 3G sound processor.
Okay.
3G sound processor.
Because initially we were not able to do for valves and all, but now we are able to do, we are getting MR compatible cardiac. Even in metal implants and bones and all also we have MR compatible ones. So we are able to do imaging in ortho as well as in cardiac now, but not yet in ENT.
Wonderful presentation, Sunita. I think you covered a lot of things. Yes, I think a couple of things mentioned about the MRI. When we started many years ago, I think we only had a CT scan at the time. CT was the only one. And later on, MRI became a protocol. Because when we started finding these absent nerves or, the cochlear aplasias and neuropathies, then MRI is a must. Actually, without that, I think you're not supposed to do cochlear implant. Because there may not be a nerve where we are talking about brainstem implant in the next talk of mine. The other thing is I found in England and Australia, where I worked many years, particularly England, they only do MRI for small children rather than CT rather than omit because of the radiation involved. Of course, anesthesia is a must for whatever. So that's how MRI is a must to identify these problems, okay, of absence nerves and other things. The other thing you're mentioning about the hypoplastic lateral semicircular canal, yes, we do find in the reports, but not necessarily they cause any hearing loss or anything. But I do come across more when I deal with the congenital conductive hearing loss. You know, some patients we do come across where congenital fixation of stapes. There I send those specifically for you to highlight the ossicles. When I have a patient with autosclerosis bilateral classical, I don't bother to do a CT. But when I have a small pinna or little narrow ear canal, and these are the cases, troublesome cases, because they have congenital conductive hearing loss, where there's slight risk of perilymph gush when you are drilling on the foot plate, a little more risk of sensorineural hearing loss. That's where certainly I insist on highlighting the ossicles and then see whether it's autosclerosis, whether you see any, like what he said, fistula antifenestrum and the thickness of the foot plate. In the congenital conductive hearing loss, you may not see anything. You may not see any autosclerotic focus. So that's why I think we should do, if you're suspecting any congenital conductive hearing loss, you must do a CT to explain the risk to the patient. Even yesterday I had a patient. So those cases, I think the results, you have to tell them that there is a little bit more risk with the outcomes. When there is a perilymph gush, there may be a small risk of sensorineural hearing loss. Not that common. I've done quite a few, but not that perilymph gush is not that common, but you should tell. Thank you so much. I think it's really a wonderful, she enlightened the radiology. We have one of the best, radiologists in the city, I must say, Sunita. Whenever we have a problem, we send the patient to her. Huh? So she has enlightened a lot of problems with the pre-op cochlear implant view.
Thank you for the kind words, and of course my knowledge would have been very insufficient if not the support from the ENT surgeons. I'm always really grateful, and I would want to say, since he said, I have to acknowledge my teacher, Dr. Jogarao sir, who's in Australia now. He's the first one who introduced me to temporal bone imaging, and I think the first set of temporal bone study I did was a thesis for a Gandhi student just after I finished my post-graduation. I think definitely thankful to the entire audience of ENT, because my learning curve would have been incomplete if I didn't have this kind of interaction from all the senior surgeons who always keep telling me, and some of them even out of curiosity I also ask, so what happened after the surgery. Some of them, in fact, nowadays I think advantages of WhatsApp is they share the images to me, so that's also a little exciting for me sometimes where I've gone wrong. Sometimes I could have not mentioned something, so it makes me wiser, and in the next report I look at it with much more carefully and I see did I miss out something else. So thank you all, and thank you for inviting me here. I think my second talk in ESI, but the first one was I think way long ago when it was just established, I think, the medical college. Thank you all for...
just one question.
Sorry.
There are a lot of studies coming up regarding doing 4-hour delayed MRIs in Meniere's disease and labyrinthitis.
Okay. Thank you so much for asking that. That is what I'm trying to develop, but we recently got a 3T, and we've only done 2 trial studies because I've requested some of the ENT surgeons only to send me even as academic cases for Meniere's disease. I would say, I think I should be able to tell you successfully in the next talk that I do amongst ENT community. The concept of doing the 4-hour study, we have a couple of papers. One is to separate the perilymph from the endolymph. So we are trying to get the sequence right, but unfortunately, I am not able to tell very confidently. I haven't still started doing it as a billing study, because first I have to gain confidence as a radiologist that yes, it's going to be beneficial for the patient and the clinician. As you're all very well aware, Meniere's is endolymphatic hydrops. So the concept is we are trying to separate the signal of perilymph from the endolymph on MRI, and we get two different signals on MR for perilymph and endolymph, so that I can tell you that usually you know that the ratio between the perilymph and the endolymph is almost equal. So whenever there is endolymphatic hydrops, it's going to be more than 50% or greater than what we are seeing the signal from perilymph. Yes, I have requested and done a 4-hour delayed scan for one of, in fact, the patient itself was a doctor, but it did not come out very well, so I will not be able to speak to you very confidently about that. But I would want to get your name so that maybe after a month or so, when I've really cracked the Meniere's disease, I would be able to tell you. But yes, I think a couple of months I should be able to get both of them right. One is to get sequences separately for perilymph and endolymph, and one to look at delayed enhancement of the endolymph in the post 4-hour scan. We've done only 2, but we're not able to get the images properly. You know that MR, that is the disadvantage of MR, that we have to do those thin sections, and you're well aware that we would not get many sections of the endolymphatic, like the cochlea. We won't get too many cuts. We get like 3 or 4 cuts. So I have to look at those 3 cuts on the post-contrast and give the information. But yes, thanks for asking that, because I've just taken a little back foot on that, but now I'll push it forward. In fact, I've asked the company, the main apps guy, to come, and then he's also working on it, because the company has to give me that sequence. The protocol has to be set by the application person from GE, whichever company, whomever you buy from the machine, they need to do it from the application end. Thank you all for a patient hearing. I think it's been a very interactive session. Like to talk in forums like this. Yes, please. Quickly, last question, because I have to go somewhere. So.
Good afternoon, madam. As you have mentioned, the quality of anatomy falls as we take thinner sections in MRI. The question is not related to cochlear implantation, but the question is exactly not related to cochlear implantation. In Bell's palsy, we need to identify the exact segment where the facial nerve is involved. So how do you suggest?
CT. If you remember, you are talking about the facial nerve, and you want to identify all the segments of the facial nerve, right? Is that your question?
Yes.
Yes, you can identify all the segments of the facial nerve on CT. That too, you can't expect to identify on a single slice, so please be careful where you are doing it. I don't know from which, I think nowadays all the government, ESI has a fantastic set of equipments. So I don't know, I think, sir, government ENT has a 16 slice, I think, sir. 16 slice also.
In CT, there will only be the bony detail, not the soft tissue detail. I
am not able to get your question.
In CT,
you are talking about the facial nerve.
Yes, facial nerve. In CT, we can only delineate the bony detail, not the soft tissue.
Why are we able to delineate the facial nerve on CT?
We can delineate but is it narrowed or not?
I am not able to get your question. I'm sorry. Okay. Okay, I got your question. Yes. Okay. If you want to look at the facial nerve, all the segments, CT is your modality. But if you want to look at Bell's, Ramsay, but Bell's isn't it like a clinical diagnosis? I don't think we get a lot of requisitions unless there is a suspicion. Bell's is actually a clinical diagnosis. Imaging is not really mandatory for Bell's. But if you want to look at facial nerve lesions, as you're saying, yes, MR has to be done, that too with contrast. We cannot pick up lesions on a routine MRI of the inner ear or cochlea without contrast, because it's a very thin structure. Even if it is neuritis, yes, we can pick up, but you have to advise a contrast enhanced study. That too of an MRI. If you want to pick up facial neuritis, Bell's palsy or small facial neuromas, yes, we have picked up. But on CT, it's very insensitive. We can tell you the entire course. Yes, I can tell you it is bulky or not. I can tell you whether it is hypoplastic or not, which you said it's narrowed or it's enlarged. But I cannot tell you it is inflammatory, because neuritis, as it says, is inflammation of the nerve, which can be picked up only once you give contrast. The whole point of why we give contrast in imaging is to pick up inflammatory or tumors which take up the contrast. I hope I've answered your question. Yeah. Thank you all for a very patient hearing.
Thank you so much, ma'am. That was an amazing radio analysis. Now I request Dr. Vishnu Swarup Reddy sir to please come ahead, and Dr. Vijay Praveen sir to please come and felicitate ma'am.
You want? I'll do that. No, you may have to eject, no? Okay, you can. Okay, ma'am.
The next talk we have is by Dr. N. Vishnu Swarup Reddy sir, who is the head of the department and chief consultant ENT and facial plastic surgeon from CARE. Thank you, sir.
I'll finish and go. Finish the 2 talks. Before lunch, we'll finish both talks. And I got to go. Good morning, all of you. So it looks like a lot of postgraduates here. I think, am I right? Or most junior doctors. Of course, some senior doctors are there, like Dr. Sudarshan Reddy and Professor Lenin. And so I think we are talking about more advanced things here. That's why I'm asking. I think probably if juniors are there, more basic things also should be learned. How many of you are doing cochlear implants here? Would you mind to lift your head up? Okay, that's good. Yeah, I think here we have too much of information. That's why I was just wondering. Yes, this is actually an interesting case. I thought I would share, and I have seen the list of topics in the program. Any cases, interesting cases, Dr. Vijay asked me, and he insisted me to do on brainstem, artery brainstem implant also. And thank you, Vijay, for inviting me to give these talks. I think I will also have to go in the afternoons. So we will try to finish these 2 talks before lunch. And this is an interesting case, probably is once in a lifetime opportunity for any ENT surgeon. That kind of case it is. I thought of sharing with you people. And then we will go for the brainstem implant next. The labyrinthitis ossificans in chronic bilateral mastoiditis with discharging mastoid cavities and very wide thumb size meatoplasties, both the sides. And then on top of it, he also had a fungal sinusitis. And you can think of the tough time to do the cochlear implant surgery in this particular young man of 24-year-old actually. He is obviously a postlingual adult. That means he has a good speech. And he is worth making him hear better, to get back to his normal education or work or whatever. He is a 24-year-old male. He presented to our department with bilateral profound hearing loss and bilateral discharging mastoid cavities and very wide meatoplasties, more than a thumb size, as I said. Both the sides, after he had undergone 3 radical mastoid surgeries at CMC Vellore actually, interestingly. It's a very good institute, well known. Both years, he had a discharging years since childhood, and he had 3 radical surgeries both the years, but unfortunately his problem has not been solved. This is, I'm talking about 5-6 years ago, when this gentleman came to me. And this was his probably initial scans where You can see here yes, you can see very wide meatus. You can see some, mucosal thing thickening, like it's not well defined. These are the initial scans. Interesting, I have never used facial latter for tympanoplasty. This is the first time in my life, because after 5-year surgeries also, after 5 tympanoplasty also, 6th time also you could find some temporalis fascia where you can use it for revision surgeries. But interestingly, here there was no temporalis fascia, because 3 times he was operated in a reputed institute, CMC Vellore, and there were no temporalis fascia left there. Then I had to use the facial latter after clearing the disease for tympanic membrane grafting and to line the cavity. You can see these preoperative the CT scans. You can see the cochlear turns here. I think Manoj, can you help me with this? I think you have to get the pointer, isn't it? Or you can use this, I think. You can use this. Laser pointer is there, right? The laser pointer. This is the pointer. Which one? Oh, this way. This one? Oh, okay. Fine then. Yeah. Yes, yes. Yes. Yeah, you can see the. Oh, sorry. Yeah, I can see the cochlear turns here. And this is the MRI actually. You can see the nerves and the signal here. You can see very well. This is about when I saw him first. And then, after the surgeries, yes. He was waiting for funding actually. When he is from Kadapa actually. He was after Y.S. Rajshekhar Reddy to get some CM relief fund or something. While waiting, and also we wanted to observe him. See, he had 3 failed surgeries. The 4th surgery also might fail. We never know. That's why we are waiting. At least we had to wait for 6 months to see the dry ear. Then thinking of cochlear implant surgery, being profoundly deaf and not being benefited with any hearing aids. And in the meantime, he developed nasal obstruction also, incidentally. And then we did a septal surgery. And after achieving, what is this moving? Huh? Is it going away? Huh? Mm-hmm. Okay. Nice. See, after achieving successful dry ears both the sides, he was observed for over 1 year duration while waiting for the funding for his cochlear implant surgery, as I mentioned. After 1 year, he again presented with a very small anterior perforation left side close to the eustachian tube area, and there was thick green rubbery jelly like discharge coming from the right ear. And a CT scan of paranasal sinuses at this stage showed a left maxillary sinusitis, as you see. This was actually the fungal sinusitis, allergic fungal sinusitis he had. And again we operated, and that was coming through the eustachian tube into the middle ear. That's what is the jelly like substance observed in the middle ear. And he underwent endoscopic sinus surgery, and the biopsy and microbiology of the material has confirmed as allergic aspergillosis. The same material was going through the eustachian tube and presenting in the left middle ear. After treating the fungal sinusitis, his left ear was explored, and eustachian tube opening in the middle ear was plugged with. So you need to do a blind sac closure. You should have an intact tympanic membrane, or if there is open cavity, you have to close the meatus if you want to do the cochlear implant surgery. So that's why his eustachian tube was plugged with cartilage and soft tissue, and a blind sac closure of the external artery canal was done. left side. And then we observed him for 4 months after closure of the wide meatusoplasty, because again it might open. If the meatus is open, your electrode is exposed. That's why you have to have a blind side closure successful. And then after 4 months, posteriorly we went and tried to do the cochleostomy. He's got an open cavity anyway. So when we started doing cochleostomy, there was ossification. All this process took nearly 3 years. By the time I attempted my cochlear implant surgery, with all these operations he had, then when I was doing cochleostomy, there is ossification. So we could not introduce the electrode. It is then we realized, cochleostomy, the cochlear, cholesteatoma or a chronic mastoid disease also can cause labyrinthitis ossificans. Then I had to abandon the procedure. And then this is the blind sac closure. I don't know how many of you have seen here. This is the blind sac closure. You have to do this in open cavity if you want to do the cochlear implant surgery. This is moving on, Manoj. And then, as I said, 3 years time was over. After his first CT scan and MRI scan was done, while waiting for the cochlear implant surgery, I had to repeat a CT and MRI to see what is happening there. And the left ear was showing ossification, and in the right ear it shows minimal ossification at the basal turn, and remaining cochlear turns with cochlear duct was patent. Fortunately, that has given a hope. Okay, the other side is ossified. The one side, we do deal with post meningitis patients with ossification. Sometimes you have to drill out to introduce the electrode. So you may be, even if you introduce 12 to 15 electrodes, they can still hear. So that's why here there was a little ossification at the basal turn. So then that has given a hope. Then again, you can see now, this is what she was saying, Sunita also, Dr. Sunita Lingareddy was saying, this is very deceptive. When you see this kind of thing, you think that it is patent. That's why MRI can give correct information, early changes of ossification. That's why MRI is a must. You can see here the fluid, and here you don't see anything. This is what is the ossification. Here it is, it has given some hope for the right-sided cochlear implant to make him hear. And these are the reconstructed images. Now again I have done the blind sac closure of the right ear and plugged the eustachian tube, and he was again observed for 4 months for healing of the external artery meatus, and his right ear was approached again by post-auricular approach for cochlear implant surgery. And this was, can you imagine, this was his 14th operation in the process of improving his hearing. He had so many operations, and you had to appreciate the interest of him and his parents to persist. See, only good thing is here, I used to do his procedures at care hospitals under local anesthesia and with very minimal hospital expenditure. That's why he came. Otherwise, if you keep charging him every time, he won't be coming here, particularly when he was waiting for the CM relief fund and other things. So that's why, because it was a challenge for us also to make him here. So then that's why it became a 14th operation. Then the cochlear, there was minimal ossification at basal turn, which was drilled away, and successful cochlear implant surgery was carried out using cochlear freedom contour implant with AOS insertion and all 22 electrodes showing neural response telemetry. So finally we achieved, after all the hassle we had, of 14 operations, and it was a great relief for surgeon and for the patient and family as well. After a 4-year struggle, we could do the implant successfully, and he had been followed for after, he needs post-op, being a post-lingual, he doesn't need that much therapy, at least 3 to 4 months. So you can see this is the right side, the cochlear implant and the blind sac closure. The volume is there. The volume. Huh? Oh. Oh, sorry. Hmm? See the volume. See, I think we'll go. What we'll do? 1 second. See here, we'll check the. Let me check the volume here. It's full, is it? Is it not coming in? No? Mm-hmm. 1 second, it may be coming in. Oh. See, I recorded actually post-op. The conversation is there with the patient, which I wanted to play. Finally. Hmm?
HDMI is there, no, sir?
Uh-huh.
So it will not be HDMI is there. It should go there.
What I will do, I will remove this one. Can I remove this one? Yeah, and then put the Babu. Hello. I'll remove this one, and then now I'll play. Hmm? Yeah.
Display.
Yeah. Okay. Okay. Hmm? Yeah. Now it's coming up. Display will go. Yeah, doesn't matter. Display can go. Oh God, what happened? This one? Can we go for this now?
No, sir, it will not.
Huh? Huh?
Display not correct.
No, display, okay. Now the volume. Yeah, volume is there now. 1 second. And now it will come, I think. Huh? Ah, Jesus. Yeah, let me see. Yeah, now it's working. Now it's working. Yeah? No, 1 second. No, 1 second. Volume. Can you hear? Where is the volume? ఇప్పుడు మీకు అన్ని మామూలుగా వినిపిస్తున్నాయా?
మామూలుగా వినపడుతుంది సార్.
ఓకే. ఓకే, ఐ జస్ట్ స్టార్ట్. ఇప్పుడు నేను మీ పక్క నుంచి they fixed it. Oh. Huh? Yeah. The volume will come now. Huh? Yeah, this is the one. Yeah. Now is ready? Is working? Yes.
మీ పేరేమి చెప్పండి.
నా పేరు సిద్ధయ్య.
మీ ఫాదర్ పేరు?
మా నాన్న పేరు ఓపడేష్.
ఓకే. మీకు ఈ కోక్లియర్ ఇంప్లాంట్ ఆపరేషన్ అయ్యి ఎన్ని రోజులైంది?
1.5 సంవత్సరం.
ఓకే. ఇప్పుడు మీకు అన్నీ మామూలుగా వినిపిస్తున్నాయా?
మామూలుగా వినపడుతుంది సార్.
ఓకే. సో ఇప్పుడు నేను మీ పక్క నుంచి మాట్లాడుతున్నాను, ఒక సైడ్ నుంచి మాట్లాడుతున్నాను, అయినా కూడా నీకు క్లియర్గా వినిపిస్తా ఉందా?
క్లియర్గా వినపడుతుంది.
ఓకే, చాలా సంతోషం.
సారీ.
యూజ్ చేస్తూ ఉన్నారా?
సెల్ ఫోన్ బాగా వినపడుతుంది సార్.
ఓకే,
సారీ.
సో సెల్ ఫోను తర్వాత మ్యూజిక్ కూడా బాగా. సిద్ధయ్య, సెల్ ఫోను యూజ్ చేస్తూ ఉన్నారా?
సెల్ ఫోన్ బాగా వినపడుతుంది సార్.
ఓకే, సో సెల్ ఫోను తర్వాత మ్యూజిక్ కూడా బాగా వినిపిస్తుందా? మ్యూజిక్
బాగా వినపడుతుంది సార్.
ఓకే, వెరీ గుడ్. ఓకే,
ఓకే, దట్ ఈస్ ఆఫ్టర్ 14 operations. So so maybe it took about 4 years, and I thought of this is for any surgeon, it's a lifetime experience, and one should share. When Vijay asked me that I have an interesting case, so it's worth doing for him. He's a postlingual adult and he has a lot of future. We'll go to the next presentation. The next presentation is on auditory brainstem implantation. Yeah, leave it, I think. Better leave it, I think. See, normally I share these images where I worked in England for more than a decade in Staffordshire General Hospital. I worked as a consultant there, and this was my last job in England in 2003. I moved to this is snow covered in Aberdeen, Scotland, Aberdeen Royal Infirmary, where I worked as a consultant and returned to care hospitals in the year 2003. Auditory brainstem implant. So what is it and how does it work? And who are the candidates for this? How is it done? And what are the outcomes? And what is the future? That's what we wanted to discuss today. The first auditory brainstem implant was done by William House in 1979, and Hitzelberger is a neurosurgeon in the Hauser Institute, where I did an attachment in the year 1999. They worked together, Darrell Brackman and Hitzelberger, they were working together when I was there. But the first auditory brainstem implant was done by William House, and it was in 1979. Earlier, I think Dr. Lenin was saying about the first cochlear implant history in 70s. So later on, they have developed, Medal has developed an implant, and then the electrodes have increased from 8 to 21 electrodes. This is how the device looks. As you see here, this is you can see 21 electrodes here, and this is the receiver.
And in 1991, 25 patients were implanted, and but unfortunately, oh God, again this problem. Six of the 61 implanted had useful auditory sensation. 24% of the electrodes could not be used because of non-auditory sensations, because brainstem is a place where other things can be stimulated. You know, you have a respiration, and the vital structures are there, and other cranial nerves are there where you don't want them to be stimulated. That's the main hurdle with the auditory brainstem implant. And the current auditory brainstem implant, as you see here, the 21 electrode arrays, and it is similar to the cochlear implant, but transcutaneous radio frequency transmitter and a receiver it comes with. As you see here, this is oh God. You can see the electrode array. It is foramen of Luschka, and it is in the nucleus, the cochlear nucleus. It is inserted. As I said earlier, it was first developed by William House, and the introduction is into the foramen of Luschka, and it has a removable magnet, as you see here. And later on, the penetrating electrode also has been developed, but it has not been very successful for the outcomes, particularly for the midbrain, inferior colliculus. They have inserted. See, the auditory brainstem implant was mainly started for the patients with bilateral acoustic neuromas in type 2 neurofibromatosis. Patients, those who have lost nerves, they don't have any nerves because of the tumors. That's how the auditory brainstem implant has been started initially. The problem is not only the nerve, and the nucleus also gets affected to some extent. That's why the outcomes are not that wonderful. Actually, the outcomes are better in other patients, like cochlear, the aplasia or hypoplasia, or absent nerves, and other indications, bilateral ossification due to meningitis. These are all other indications where the hearing results are better than the type 2 neurofibromatosis patients. But in the evolution, the penetrating electrode also has come, but it has not been very successful. You can see the electrode here. So what is the benefit of ABI? It is limited to environmental sound perception, and it helps for the lip reading, and rarely they get open set speech understanding. And definitely the hearing is poorer than the cochlear implants. As you see here, the bilateral acoustic tumors, so for effective and partial hearing restoration in patients with type 2 neurofibromatosis, and that's the most common indication started, and 12 years FDA approval they got for 12 years plus. After the schwannoma removal, it can be done after first schwannoma removal or second. And also other indications, as I mentioned, who have failed cochlear implant surgery and loss of the nerve integrity because of skull base fractures or any traumatic avulsion of the cochlear nerves, and severe post meningitic cochlear ossification, and cochlear dysplasia or cochlear nerve aplasia, but hearing outcomes are better when compared to neurofibromatosis patients. These are the other indications, and there are severe malformations also, like earlier she was mentioning about the congenital anomalies, like Michel's dysplasia, where there is no cochlea at all, and it has to be the parents have to be committed, or the patients, because it needs a lot of patience. It's not like normal hearing. You need to have a it's not like cochlear implant. They have to have a lot of patience to wait for the outcomes. The cochlear nerve aplasia, as you see, this is a CT. The MRI of cochlear nerve deficiency, we can see some examples here. So these are the candidates for auditory brainstem implant, and the surgical approach can be translabyrinthine. It is because usually with the same approach you remove the tumor, we remove the acoustic neuroma, and then do the simultaneously you can do the auditory brainstem implant in the same sitting. So that's why it can be done after the first surgery and put it in a sleep mode, and then after the second surgery removal of the tumor, you can start using it, because there may be distortion also with the two tumors, and retrosigmoid approach also can be done. See, the post-operatively you need to do a CT scan to identify, to confirm it, and also you need to have pediatric ICU, because when you are activating it, you should have an emergency setup, because vital structures also can be stimulated, other cranial nerves can be stimulated. That's why you should have an emergency setup in case of any emergency. Here you can see these are the cranial nerves, 8th, 9th, 10th, 11th, 12th, and here this is a landmark for choroid plexus, where you have the foramen of Luschka, where the cochlear nucleus is there, where you insert the electrode. You can see the electrode insertion there. Then later, as I said, these penetrating electrodes came, but the outcomes are not that great with the penetrating electrode. As I mentioned earlier, for the midbrain, I think in the inferior colliculus it has been tried, and because these are in patients after tumor removal. The timing can be after a second vestibular schwannoma removal, or it can be after first also. This is the implant bed. You can see the dummy there, receiver. You can actually, I had in the 99, when I was in Hauser Institute, I was fortunate to see the first auditory brainstem implant, and then again I was in Hanover, University of Hanover, with Thomas Lenage, Professor Thomas Lenage. They were doing a 50th auditory brainstem implant, and these are the pictures from that live surgery. Actually, the dura is open there, and you need the help of the neurosurgeon. Professor Samier was doing it, and this is the receiver, and you can see the electrode here. This is where is the electrode in place. I have a small video clip. In fact, I have a tape video, actually video tape from 99, still with me. First auditory brainstem implant I witnessed, and we converted it into the DVD recently, and then we could edit, but the pictures, the quality is not that great.
Manoj, I think. Yes. You can see a small clip of video. You can see the dura being incised there. And then you are retracting the cerebellum. And inside the arachnoid and empty the CSF. You are incising the arachnoid to empty the CSF to see the nerves. And then you can see the nerves. And then you insert a dummy electrode. The dummy electrode being placed there. And then you go for the true electrode in place. So you have the landmarks, choroid plexus, and then the stump of the artery nerve and into the cochlear nucleus. It is the lateral recess of the brain. That's where you insert it. And then you can put some tissel glue. You can put some Surgicel or tissel glue. I think they used to use Teflon actually to pack that area to keep it in place. Nowadays we have the fibrin glue, it can be used. The operative and perioperative care, and once you have done that, you have to test it for the presence of EABRs, evoked artery brainstem responses, and to see that it's helping. And you also have to put some electrodes to see whether other cranial nerves are getting stimulated. For the glossopharyngeal, you put it on the soft palate, and on 9th, 10th, 11th, because it can cause problems later on for the swallowing or for the, the vagus, supplying recurrent laryngeal nerve and vocal cord palsies and other things, aspiration, and also the vital signs have to be checked while switching it on, and adjust the electrode for adequate positioning as necessary. And the magnet is removed and ground electrode will be placed in the temporalis muscle, and the wound is closed. And receiver antenna, where the area is shaved, and adhesive retainer disc containing a small metal tab is placed. The transmitter coil magnet adheres to this tab. The complications, later on, there are a few cases of cerebrospinal fluid fistula through the wound has been reported. And again, like hydrocephalus and displacement of electrode array, and mainly non-auditory stimulation, where you have to switch off some electrodes. You can't use all the electrodes. Wherever it is causing non-auditory stimulation, it can cause some dizziness or the stimulation of the facial nerve and other things, where you may have to switch off the other electrodes. Tingling, as I said, discomfort in the throat. This is the post-operative. You can see the electrode in place after artery brainstem implant. You have to do a CT scan to confirm it. And device activation and programming, usually after 6 to 8 weeks after implantation. And as I mentioned earlier, the non-artery responses due to electrical stimulation outside the cochlear nucleus complex should be switched off. And one should have the emergency facilities, whether any risk to the vital signs. When you are switching on first time, you should have the emergency medical assistance should be available. And setting of threshold and comfort levels, evaluation and management of non-artery stimulation and pitch scaling has to be done. And you have to switch off some electrodes which are causing annoyance. The take-home message about the artery brainstem implantation: it is an effective method of partial hearing restoration in patients with neurofibromatosis type 2, and it provides environmental sound awareness and helps for the lip reading, and open set speech perception achieves only rarely, like using telephone and other things. It won't happen in every patient. And the trials of penetrating ABI and the artery midbrain implant have not shown any improved hearing and better speech perception in patients without neurofibromatosis and the type 2 tumors. And future improvements we have to see for the better outcomes. This is what the current status of the artery brainstem implant. Thank you so much for your patient listening, and any questions you are welcome. Thank you. Pleasure.
Thank you very much for an excellent presentation. My doubt is, what is the exact site of stimulation by ABI? Whether is it the dorsal cochlear nucleus or the ventral, if it is ventral, anterior or lateral. Why? Because ventral is not accessible that easily, yes, but ventral is the most recommended site.
Yes.
So how do you proceed with that?
See, basically, as you said, the dorsal and ventral, where you have to put insert the electrode and check all the electrodes and see the functioning. That's why it is a matter of adjusting when you are inserting into the foramen of Luschka, where the electrode plate electrode is inserted. As you said, the adjustment of the electrode, that's why you have to check on the table.
Yeah, but what is your target site?
The target is
ventral
dorsal,
or the dorsal?
Dorsal, I think.
Okay.
Yeah. Can you identify yourself? I don't know. What's your name, doctor? Huh? Oh, Satya. You are Satya Kiran. Yes, oh, sorry. We haven't met before, have we?
Yes, sir.
We met.
Implant surgeon at Rainbow Hospital.
Oh, okay. Yeah, I know. I heard you have seen your name in the program also. But we communicated, but we haven't met, I think.
No, we have.
We did met, is it? I'm sorry, I think I've forgotten then.
That's okay.
Okay. Any other questions? See, this is advanced CMA, that's why I think Dr. Vijay asked me to talk on this. And I hope you learned something out of it, because there is a lot of research and development is going on. Future, things might change. We might get even better results in future. Thank you so much.
Thank you so much, sir. That was a very rare and informative presentation. I would now request Professor Dr. L. Sudarshan Reddy, sir, to please come ahead and felicitate sir, and Dr. Vijay Praveen, sir.
Thank you.
I invite every one of you for the lunch now. It's arranged in the same floor. And a small announcement is that we need to gather in the 120-seater auditorium just next to the lunch. This hall is being taken by some other guys. So we need to gather at 120-seater for the afternoon session. Please remember. It's in the same floor next to the lunch.
Most important point for you to get posterior tympanotomy the same. So where to drill exactly to identify the posterior tympanotomy is a very big question to the juniors over here. So the best is to delineate the facial nerve before you go on to the posterior tympanotomy. So where exactly does this facial nerve lie in the mastoid cavity? Simple thing, you identify the incus short process, you identify the digastric ridge, draw an imaginary line from the short process of the incus towards the digastric ridge. There is an imaginary line. Posterior to the imaginary line drawn from the short process of the incus towards the digastric ridge, the facial is almost always posterior to it. So you drill a little bit anteriorly just underneath the short process of the incus to open facial recess cell. One cell may be very constant, which is called as sentinel cell. And I would like to even say something about the facial recess boundaries. The superiorly would be the incus buttress or bar or incus bridge, which is a thin piece of bone just underneath the short process of the incus and the short inguinal ligament. Inferiorly would be the caudofacial angle. The facial comes like that, and the cauda exists this way anteriorly, just underneath the level of the tympanic annulus. Posteriorly and medially would be the facial nerve. Anteriorly and laterally would be the cauda tympani. Again, I repeat the boundaries of the posterior tympanotomy. Superiorly, it is the incus bar or the buttress. Inferiorly, it is the caudofacial angle. Posteriorly and medially would be the facial nerve. Anteriorly and laterally would be the cauda tympani. So once you make this area saucerized, now here there is requirement of saucerization as you go deep in and open the facial recess cell and gain access to the middle ear. Opening of the middle ear or the tympanic cavity from the mastoid region is called as posterior tympanotomy. Why? Because you are opening the middle ear. By me or anyone known to me. This is described when the facial is very, very, very anterior and you have no space to go anterior to the facial nerve, instead with the inferiorly extended facial recess. Now, there's something called as anteriorly extended facial recess 2. This can be done by giving cuts in the external auditory canal, bony, only on the bony canal, not over the skin. And you can push the external auditory canal a little bit anteriorly and you can gain space anteriorly. This can be done when the facial recess is very narrow or the cochlea is rotated anteriorly and superiorly, or in any case where you need to do a facial nerve decompression as described here. This I have done in a case of facial nerve decompression, not in a case of cochlear implantation. And this technique has been described by one gentleman called as Craig Buckmans, and the technique is called as Craig Buckmans technique.
Now, after you gain access to the middle ear, what is the thing we need to look at? We are interested in opening into the cochlea. So the direct entry or the window into the cochlea is nothing but the round window here. But round window is not round, it is triangular in shape, apex directed inferiorly and usually hidden by a bony ridge called as round window niche. Round window niche is nothing but a bony covering posteriorly and superiorly, covering or hiding the round window membrane. So this is also called as operculum, which has to be drilled out at very low speed using a diamond burr so as not to cause acoustic trauma, so as not to cause thermal trauma, so as not to cause mechanical trauma. These are the three types of trauma when you do a high speed drilling on the cochlea. So it should be avoided and should be done by a diamond burr and at a very low speed. You can even go with 1000 RPM. And the depth, how much depth you need to drill out the round window niche to expose the round window membrane is a question. So you need to drill at least 1 millimeter to gain access to the round window membrane visibility, and you should be seeing all the round window membrane at one stage at a 360 degree fully. Okay, even when you want to perform a round window approach insertion or a cochleostomy or an extended round window, it should be delineated fully 360 degree. Sometimes there is even a membrane over the round window membrane appearing like a thin layer of mucosa which should be taken off. The round window membrane in reality is very, very dark. Once you have an access to a window here, you can directly go through that, opening the round window membrane very carefully by giving a slit like incision using a needle or any instrument like a right angle pick or a needle, and it should be directed in such a way that it should be anterior to posterior superior so that the round window membrane can be opened like a window before you go and insert an electrode array. So this is a round window approach, and here is a cochleostomy usually done for a few types of electrodes which Dr. Manu is going to describe on. This is called as bony cochleostomy or conventional cochleostomy. The conventional cochleostomy is done inferiorly, approximately 1 to 1.25 millimeters inferior to the round window membrane. So you have round window approach, you have cochleostomy approach. There is something in between the two which is called as extended round window approach. That means you extend the round window anteriorly and inferiorly. Okay. Now, when to do a round window approach, when to do a cochleostomy. Simple thing, you identify a round window membrane 360 degree, you measure the angulation formed by the round window membrane with the posterior tympanotomy angulation. If you are using a perimodular electrode, no doubt you have to go for a bony cochleostomy. If you are using a lateral wall electrode array or a mid-scale electrode, if the angulation is less than 45 degree, you need to go with a round window membrane insertion. If it is more than 45 degree, you need to do a bony cochleostomy. The perimodular and the type of electrodes Dr. Manu is going to describe on, and it's always better to open the window into the cochlea just prior to electrode insertion. You keep everything ready and then open it and just insert it and come out. Now, how to insert an electrode? You can either use a freehand technique, or a few manufacturing companies even provide an insertion tool which is easier for a beginner. Nowadays even robotic and magnetic guided electrode insertions are also available, which have even the tactile feedback or a mechanical feedback. So the insertion should be as atraumatic as possible, and if done under some fluid like dexamethasone or methylprednisolone, you can visualize the round window membrane depending upon the viscosity of the solution, and this insertion, this type of insertion with a liquid over the round window membrane is called as steroid lake insertion, described by Dr. Gunesh Rajan from Australia. So the insertion time should be as lengthy as possible. the minimum time duration for an electrode to be inserted completely is minimum of 30 seconds. And the electrode contacts, if at all it is perimodular or a half-banded unpaired electrodes, the electrode contact should be directed towards the modulus. Why? Because the nerves are directed towards the modulus. And the direction of the electrode should be anterior, inferior and medial. Almost always, whether it is functional endoscopic sinus surgery or cochlear implantation or mastoidectomy, the approach is the same: anterior, inferior and medial. So when you go for a round window insertion, we need to be careful about one bony structure called as crista fenestra, which can hook the electrode away from the direction of the scala tympani of the basal turn. And please aim for a complete insertion, and the jog or the marker ring should always be directed inferiorly, saying that your electrodes is on to the other side, directed towards the auditory nerves. This is a small picture of a temporal bone dissection which shows the round window membrane area, conventional cochleosteum area, in between would be the crista fenestra. Now, after you completely insert an electrode, you need to seal the area of electrode entry point. That is called as sealing of the cochleostoma. The best material would be a fascia. The other materials would be a periosteum and the muzzle. We rarely use muzzle. Here is one case where I was associated with Dr. Neelam Vaid at KEM hospital, where the promontory is very thinned out. There was a leak from here. We used muzzle plug to deal with this perilymph gush in case of anomalous cochlea, usually in type 1 or type 3 incomplete partition defect of the cochlea. Now, after you insert an electrode, after you seal the cochleostoma, you have to loop the electrode into the mastoid cavity in such a way that the overhangs will hold the electrode, preventing its misplacement or misdirection, and the electrode should be directed not towards the tip but towards the antrum. Why? Because it is the tip which grows, it is not the antrum which grows, it is the tip which grows. When you do a pediatric cochlear implantation, as the child grows in age, the mastoid tip is going to come down and anteriorly. So if your electrode loop is towards the tip, the electrode will migrate outwards from the cochlea. So it shouldn't be done. After you make a loop of electrode, the time is for closure, and it is a layered closure. The periosteal or the flaps are closed with an absorbable suture material, the T-shaped incision which is closed, and then for the subcutaneous or the skin, you can use a monofilament. Usually you go for monocryl 40, and after you close the incision perfectly, you can apply something called as steroid tapes or steroid strips, and over which a standard mastoid bandage or a tight bandage is to be applied, which is going to remain for at least 3 to 5 days. So this is about the surgical aspect. If there are any questions, I would like to be very happy to answer it. I would request the juniors to come forward with their questions so that you can get benefited at the max. Any questions? Yeah, please go ahead. Is it done through? No. I really don't know what is Arnold's triangle. Can you describe it? I really don't know. Okay. Then no. That means you are describing a triangle, Arnold's triangle. What you are saying is the base is anteriorly would be the facial nerve mastoid portion, posterior superiorly would be the lateral semicircular canal, and posterior inferiorly would be the anterior portion of the posterior semicircular canal. No, it is not the area. No. It is just behind the facial nerve in the retrofacial air cell system. No. Extended hypotympanotomy. I really don't know what is extended hypotympanotomy. See, retrofacial tympanotomy I haven't seen till date. I've asked many people, nobody has done it, but it is described in textbook. I don't know what exactly is extended hypotympanotomy? I'm really sorry, I really don't know. Is there anyone who could answer that? I haven't heard extended hypotympanotomy. Where is it described? I mean, did you read it? Which book? Okay, I really don't know. I'm sorry for that. I've never come across that word. No, there's nothing like an extended hypotympanotomy to my knowledge. Yeah, it may exist. Yes, that is inferiorly extended posterior tympanotomy. It is inferiorly extended posterior tympanotomy. It can gain access to the hypotympanum. Yes, that is inferiorly extended posterior tympanotomy. It's not hypotympanotomy. Anything else? Yes, please. I'm sorry, I am not able to hear you. Can anybody give a mic? Yeah. Varia technique. What's your doubt? Please come forward. I am not able to hear you. A very good question. I am a strict advocate of posterior tympanotomy approach. The FDA recommended approach is standard mastectomy facial recess approach or standard mastectomy posterior tympanotomy approach. Varia technique is not FDA approved. Is not FDA approved. It's stupid. Why? Because there's more chances of facial nerve injury. Why? Because even if you go through Varia technique, you are going to enter facial recess area itself. Yes, facial recess doesn't have facial nerve, but the access is very, very blind. Okay, it is done by a suprameatal well, and it is entered into the mastoid cavity at 11 o'clock position and entered into the middle ear at 10 o'clock position. If at all there is any difference in these clock markings, there is a chance that you could injure the short process of the incus or facial or lateral semicircular canal. Yeah, I am not an advocate. Yeah, there are a few people who do that, but there are more centers which do posterior tympanotomy approach. It is FDA approved, not the Varia technique. No, we don't recommend that. Strictly no. Any other question? Any DNB resident? See, this cochlear implantation is definitely going to come in your either viva or your theory. Yes, sir. At what stage, sir? See, any technique is surgeon dependent, technique dependent, and anatomy dependent. Once you know the anatomy by imaging, assess it by your surgical skills and the surgical techniques, and a proper visualization, your posterior tympanotomy is nothing but anatomy here. You identify or delineate the facial nerve, go anterior to it, you go inferior to the short process of the incus, anteriorly would be the chorda tympani, which is also delineated, and you have all the three boundaries and go ahead. Because in Varia technique you don't have any landmarks over there. It is always a chance. And whatever you see, whatever you do, you are able to see what exactly you are doing by standard mastectomy posterior tympanotomy approach. Yeah, you can minimize the complications. Excellent question. This is the place when I opt for Varia technique. When you have a low light dura and anti-placed or anti-post sigmoid sinus, that is the time when you think of other technique, Varia technique, or else if that is the situation, I would opt for operating on the other side. It is very, very unlikely that anti-post sigmoid sinus and the low-lying dura are there on both sides. I would take up the other side. Excellent question. Again, a question for Viva, DNB Viva. There's a difference between a gush and a ooze. Ooze is nothing but a perilymph leak less than 30 seconds. Gush is the one which is a leak more than 30 seconds. Your question was, how do you prevent or handle a case of perilymph gush? Perilymph gush is expected, okay, not encountered. It is expected preoperatively by imaging. Number one, when you have a cochlear anomaly, whether it be incomplete partition defect or whether it might be enlarged vestibular aqueduct syndrome, there you expect this gush to be there. Okay, what you can do preoperatively is you ask your anesthetist to keep a lumbar drain, number one. Number two, you can open that lumbar drain when you go ahead with your cochleostomy or you go with round window. I would always prefer to go with a cochleostomy. Why? Because you can plug the leak well rather than going for a round window membrane. That is second point. Number three, I would like to go with a muzzle plug instead of going with a fascia and pericranium or periosteum. I would like to use a plug. And usually the ooze or the gush stops by itself. Just pack the area with a gel foam soaked in methylprednisolone or dexamethasone. Wait for a few minutes, go and have your coffee and come back. By the time you come back, the gush should be subsided. And then you go ahead with your insertion. Or else, if the gush is not too much, then you can still go ahead with your electrode. And I will also use, if at all there is a very big gush which is expected, you can go for a specially designed electrode which is called as form series electrode, available with Medal company. Or else, if you want to go with a other electrode, what you can do is you can take a fascia like that. Can I have a paper, please? Suppose this is the fascia. You make a hole in the fascia. So this is your fascia. Suppose I'm going to make a small hole into this. Your electrode will come like that. Go up to the level of the cochleostomy, seal it. Got it? If you don't have the option of using a form series electrode, this is also one way you can handle with. Okay? Post-operatively, you can maintain the lumbar drain for 1 or 2 days. That's up to you. And post-operatively, you can even nurse the child with head up position, giving mannitol or Diamox, whatever you feel is necessary. Okay? And one more thing, CSF gush or perilymph gush, whenever you expect, please follow the vaccination protocols. Sometimes you may need to give a meningococcal vaccine, which usually is not given routinely. Apart from your pneumococcal vaccine and H influenza type B vaccine, you also need to give meningococcal vaccine for that. Okay? Did I answer your question? Any other question? Yeah, please. Excellent question once again. Labyrinthitis ossification is mostly due to post-meningitis event. This is nothing but ossification in the cochlear lumen. Okay? First thing what we have to do is, first we have to identify what is the severity of labyrinthitis ossification. For that you need to two imaging techniques. One is MRI, which also detects the fibrosis. Before it proceed on to the ossification, it will have fibrosis. In that case of fibrosis, the CT will be normal, but MRI would be having a loss of signal intensity on T2 weighted images. That is first thing. If at all there is frank ossification, you can detect it on CT's temporal bones high resolution. Now, again there are three types of ossification or three levels of ossification: C1, C2, C3 according to balcony. Okay, C1 is just up to the level of 6 millimeters from the round window membrane. The second two is skip calcification or beyond 6 millimeters from the entry of the cochlear aqueduct into the scala tympani of the basal ton. Why? Because the meningitis would come from the subarachnoid space into the cochlea via the cochlear aqueduct route. Okay. Number 3 The third level is complete ossification or ossification beyond the second turn. So there are 3 levels now. Now, if you have a C1 type of ossification, you can go with a extended round window technique, or a bony cochleostomy technique, where you keep on drilling very slowly using HIOPT, which is sodium hyaluronidate, and make the bony dust exteriorizing. Okay, you just take out the bone dust which is accumulated, and at one point of time you will be gaining access to the cochlear lumen. That is one technique. If it is beyond that, you can do something called as cochlear drill through the basal turn of the cochlea till you get access up to the level of the cochlear lumen. You can go up to 1 or 1.2 centimeters anteriorly till the level of the internal carotid artery. Number 3, you can do a scala vestibular insertion. This is a scala tympani ossification. You can do a scala vestibular insertion. Number 4, you can do a double cochleostomy, one in the basal turn, one in the middle turn. The middle turn, you are going to use a double array electrode, which Manu is going to talk about, and where you can insert one electrode from the basal turn, one electrode from the middle turn. Okay, these are the techniques available for cochlear ossification or labyrinthitis ossification. The last but not the least, if you are unable to do any sort of insertion, proceed with ABI, auditory brainstem implant. That's the last option to be thought of. Okay, it should be done only when there is bilateral ossification and you are not able to insert any on any side. So ABI is recommended only unilateral, not bilateral. Okay. Yeah, excellent question. Once again, you're talking about the receiver stimulator or the electrode array. Receiver stimulator should be seated in a properly made bed. It should be held with a tie down holes. And one technique where we can use is when you drill out the bed, you collect the bone dust, you mix it with antibiotic solution, and then again keep it over the implant receiver stimulator in between the bed and the implant edge, so that it will get ossified. And the other technique is, if there is any electrode migration which you are thinking of, you can always direct the electrode array just underneath a sort of bridge made at the exit point, and also you can anchor it onto the superior border of standard mastoidectomy at the level of the dura or at the level of the attic. That is how you prevent migration. And migration is always identified by radiology. Confirmed. Definitely explore. That should be definitely explored. That should be definitely. How is it identified? By radiology and the decrease in speech outcome or language outcome as the time proceeds. That is how you detect. This is called as soft failure, sorry, hard failure. Any other question from the DNB residents or postgraduates? We'll be pleased to answer any question. Otherwise, thank you very much. Thanks a lot.
Thank you so much for that presentation, sir. I would request Dr. Lenin and Dr. Vijay Praveen to please come and felicitate, sir.
Yeah, good afternoon, everybody. After that exhaustive talk, I'm going to just talk about the last part of the implant which the surgeon deals with, the electrode itself, and what the electrode is, and why there are so many companies, why there are so many electrodes, how do you pick up an electrode, how does it work, and it is the most important part of the implant which we are using. So the most important part for the surgeon is this last part. So this is called the electrode array. So the implant can have the whole thing is called the electrode. The last part is called the electrode array. The Cochlear company devices also have another electrode which is called a ground electrode. So I'm going to talk about the electrode array. So the definition of the electrode array is it's the portion of the implant which actually goes into the cochlea, and it has got stimulatable contact points on it. So what are the parts of a electrode? So each electrode has got an apex, which is the tip. There is a base. There are different electrode contacts, which are these metallic parts on it. Then you should know what is the length of an array, what is an active stimulation length, which are both are different actually. Then the number of contacts they have, what is the space between the two contacts, and some of the electrodes have got insertion depth indicators, so that when you're putting it in the cochlea, you know how far you have gone, have you reached, is the whole implant in or not. And then there are the electrodes have got some surgical handles or stillets which can be used to guide the electrode into the cochlea. So a lot of research has gone into, and a lot of companies have come up with different types of electrode. But what are they trying to achieve? So before we go into that, this is what an ideal electrode should be. So the electrode should have an atraumatic electrode insertion into the cochlea without causing any damage to any structures in the cochlea, and it should be placed in scala tympani. You should be able to achieve full insertion of the electrode, and the electrode should not spring back. That's what sir asked, whether if the electrode migrates. So it should have adequate flexibility so that once you put it in, it does not come out. And there should be easy handling for the surgeon. And if in the future the implant is explanted, because now we are implanting kids who are very young, less than 5-year-old, so all of these kids will need at least 1 if not 2 implants in their lifetime, because they're going to live till 70 years or 80 years. So after all, at the end of probably 20-30 years, the implant will eventually fail. That's what is happening with the younger kids being implanted in US, Australia and all in 85s and 90s. So it is said that the child will need at least 1 reimplantation. So when the reimplantation happens, we have the company, or as surgeons, we have to think about all that also when we are doing a pediatric child. So easy explantation should be there. If reimplantation is required, you should be able to pull out the electrode easily and put a fresh one inside the cochlea. So how does an electrode array actually work, or after all, how does a cochlear implant work at the end? So this is the structure of the organ of Corti, outer and inner hair cells. Then there are these nerve fibers which come out, and then it goes into the spiral ganglion, into the modulus. So what happens is, this is a cut section histology of an electrode inside the cochlea. So this is the electrode, and this metal part is the contact point. So when the current goes through the electrode, the current comes out through this, and it stimulates the nerve fiber or the spiral ganglion, depending upon where the electrode is placed. And this is also a section showing a similar diagram where the electrode would be in the cochlea. So this is your scala media, vestibuli and tympani. So how does an electrode actually stimulate the nerve fibers? So there are different types of stimulation. Basically the current comes through the electrode, comes out of one of the electrode points, and then it can either go back to the device or enter in different areas. So there are different types of stimulation. So one is a bipolar stimulation, in which the adjacent, basically electrical circuit has to complete. Current exits, it has to again enter, then only a circuit is completed. So this is called a bipolar stimulation, where it comes out of one contact point and enters another contact point. Then there is a common ground stimulation, in which one electrode acts as a ground, and the other electrodes act as a stimulating points. Then there is something known as monopolar stimulation, which is actually there in most of the devices nowadays, in which each electrode, each contact acts as a stimulatable point, and there is a different ground electrode or a reference electrode which receives the current. So the advantage of this is you have more number of channels, better the resolution, and the loudness is more. You require less current to stimulate, and that's why the battery life is much more. So monopolar stimulation is which is more common these days. So these are the examples. See, this is how monopolar works. So current comes out of here, received by the reference electrode or the ground electrode. This is bipolar stimulation, and this is common ground. So this is what is there in today's date in most of the devices. So we all talk about channels. So channels is different from electrodes. So channels is something like the resolution of your camera, like a megapixel. So you can have multiple channels with the same number of electrodes. So a single channel system is all sound information is delivered to only one channel, but in multi-channel the signal can be divided into various frequencies and it can be given to different regions in the cochlea to have that resolution. So, so to maintain that resolution or neurotonotopicity which is there in the cochlea, which God has given and we are trying to replicate, it's very difficult. So for this there are different innovations in the electrodes to match this. So this is called current localization or place coding. It depends upon these four factors. One is type of stimulation, which I already talked about. Then the other thing is where you place the electrode in the cochlea, and what exactly is the size of the electrode contact, and what is the length of the electrode, how far are you going into the cochlea. So the first part, the site. So initially when implant devices started developing, they tried stimulating, so they always thought that we should not go into the cochlea because we may cause some, meningitis and all that in the past, like how stapes was not done for a long time because of that same scare factor. So they tried multiple cochleostomies, making multiple holes. They tried to put it into the modulus, and they tried extracochlear stimulation. But the problem is there is a lot of resistance. You need very high current for that current to go through the bone and actually reach the nerve fiber. So finally, it was for Graham Clark who discovered that scala tympani is the right place. We have to go into the cochlea to get good stimulation. Now scala tympani is a big place. Where do you place the electrode inside the scala tympani? So it can be placed near the modulus, that is near the spiral ganglion. So in those electrodes you are actually stimulating the spiral ganglion. That is what is receiving the current. And or you can place it beneath the peripheral processes or towards the outer wall or in the middle of the scala tympani, which is the mid-scala electrode by the AB. So these are different spots where you can place it. Now theoretically they say it is better to place the electrode towards the modulus because you have lower threshold. Obviously when you are closer to something you can stimulate it much easier. You can be more pinpoint to where you are stimulating, and there is lesser current because you are directly on the nerve rather than being away from it and giving a lot of current. There is spread of current and there is a lot of power loss. But there are other factors also which come into play. So this is a lateral wall electrode. You can see it coiling along the lateral wall of the cochlea, and this is an electrode which is hugging. So these are called modulus hugging or perimodular electrodes. So these are different types of arrays depending on site. So lateral wall electrodes, the AB companies has got high focus 1J. There is the new one which has come, which is called the Slim J electrode, and the Digisonic company's electrode is this. And so there are basically 4-5 companies which are operating: AB, Cochlear, Medel, Digisonic from France, and Neurotron, which is the device developed by China. China's military has developed it, and mainly it's done in China. And the perimodular electrodes are helix electrode of the AB, but it's not used nowadays. Then there is a new electrode come out by the Cochlear company called slim modular electrode, which I'll talk about. And then there is a contour advance electrode from Cochlear. And then the AB's electrode is a mid-scala electrode, which is placed in the middle of the scala tympani, which they claim that it is in the middle. So that was the type of electrode. Now coming to the electrode contacts, like what is exactly stimulating. So if you magnify an electrode and see, this is what it looks like. So these are electrode contact points. They are basically made of platinum iridium alloy. And initially they had tried ball electrodes, but they are too traumatic. You cannot insert something like this into the cochlea and expect residual hearing to remain. So this is all outdated, this research. So there are smooth electrode contacts. And now what happens is, how big should be this contact? Why can't they just put a big plate of platinum iridium instead of making small? So the thing is, if the plate is too big, then there will be dissolution. The metal will start dissolving into the perilimb. So they can't do that. And if it is too small, then they cannot, if the electrode contact is too small, then there is dissolution, because the smaller area is discharging more current. So it will start losing the metal ions. And so it cannot be very small. And if it is too large, it can affect the localization. So usually they say that the width should be 0.3 mm, and in between the two electrode also there should be a distance of 0.45 mm. So this is a standard which is followed by most of the companies. Now depending upon the contact, whether it is half banded or full banded, that means if the electrode is there, if the contact is all round the electrode or it's just on one point. So most of the companies have got half banded electrodes, but there are full banded electrodes available in special electrodes for cochlear anomalies and common cavity anomalies, which are much better in those anomalies, because the neural epithelium is said to be present in the, if this is a common cavity, then the neural epithelium is present on the outer wall of the cavity. So you need to put something which can stimulate maximum, so you try to put a full banded electrode. So now these are the electrodes. Medal has got all half-banded electrodes, which are paired electrodes. So they're like 1, 2, 3, 4 like that. They consider this as one, but there are two. And these are the medal ones. Cochlear has got half-banded. I already told about the full-banded ones. These are the full-banded electrodes. This is a double array, which Satya was talking about. It is used in cochlear ossification, where you have two electrodes coming out, and you can make two openings and put one antegrade, one retrograde, and which covers the entire cochlear length. And these are the AB's mid-scale electrode, which has got half-banded contacts. And now there are a number of contacts which are different from company to company. It could be 24, 22 or 16 depending upon which company it is. Now the length of the electrode, like what is the length of the electrode, how long it should be. So this is the full length of the electrode, but the stimulating length is only from here till here. So full length is the stimulating length plus the buffer length. So every electrode will have a buffer length. So and the marker will be over here. So that means when you put it into the cochleosteum and the round window, you have put it till this point. Okay. And for around 4 mm there is no electrode contact. So why this buffer length is given is there are 2-3 reasons. One is you don't want current to be stimulating outside at the level of the cochlea. Patient can have some alternate sensation because there are some nerve fibers on the promontory. And also after you put the electrode in, there can be some migration outside. So that also will be prevented. And yeah. And now how do you decide what is the length of the electrode? You cannot put an electrode in right from the base till the apex. It's not possible. And why? The reason being that the spiral ganglion cells are not present throughout the cochlea. They're only present through, one quarter of a turn. And the organ of Corti is present from base till apex. So the nerve fibers are there till the apex, but if you see here at the apex there is no spiral ganglion cell. So from the apical hair cells, just the nerve fibers come, and the spiral ganglion is much lower down than that. So if you are using a perimodular electrode, there's no point sending it till the apex because there is no spiral ganglion over there. Okay. And so basically you have to see what is the size of the cochlea or the length of the cochlea and how much you have to cover. So we try to cover this, but it is rarely possible. Most of the conventional speech processors cover only from around 11 kilohertz to probably like 70 or 100 kilohertz. More than that is not covered because the human ear is hearing from 20 to 20,000 hertz. So we are nowhere near to normal, but the brain is pretty strong to use those frequencies, to read what we are doing. So this is the angular insertion depth. So this shows, how much the electrode goes in. So there is a flex soft series from Medal which goes almost to the longest, to the maximum depth. And the angular insertion depth is in angles. So how do you calculate it? So this is 180 and you add another 90 to it. So this is 270 degrees of insertion. So this is some more, add another 60 to it. So like that. So this will be around, this is around 720 degrees of insertion. Okay. So this is usually calculated post-op. After we do a insertion, we take an X-ray, modified Stenver's view, and we see this, and we can calculate how much the electrode has gone in, has the electrode bent tip or whatever, is there any complication, that can be checked. So these you can see a comparative chart showing the length of the electrode. So ABs are around 15, 17, and Medal has got longer flex soft series called 26, it's around 26 mm activation length. So there are different lengths of electrodes. Now apart from the length, even the electrode dimension is important. So every electrode is like a tapered one. So the base is wider and the apex is much thinner. So because as the cochlea, we go from the base to the apex, this is how the scala tympani changes its dimension. So if you see at the apex, it is like this, so small, triangular. So your electrode cannot have a similar diameter, throughout the length. So it has to be designed that way. This is just a slim straight electrode of cochlea showing the different parts. I won't go into that. And I already talked about antegrade or retrograde insertions in ossification. Now when we are doing all this, whenever you put something inside, there is some trauma happening to the cochlea. So this is a histological section showing the electrode sitting in the scala tympani, and this is your basilar membrane, this is your scala media, and this is your scala vestibuli. So whenever there is an electrode put in, there is some damage which occurs. So if there is too much trauma to the basilar membrane or the spiral ligament, then there will be some fibrosis, ossification, and there is a chance that some of the hair cells and the nerve fibers may die and they may not be stimulatable through your implant. So what they are trying to achieve is using thinner electrodes and to avoid this kind of damage when you are inserting. And this was graded by Eshraghi into different grades depending on the histopathological changes. So 0 is no trauma, you go smoothly into the scala tympani. 1 is the basement, the basilar membrane is elevated little bit, that's all. and in 2 there is rupture of the membrane, 3 there is dislocation of the electrode itself into the scala vestibuli. So there are a lot of implant surgeries are happening and electrode is being put into the cochlea, but it doesn't end there making a cochleostomy and just shoving an electrode in. It has to go into the right place. Your electrode may as well would have gone into the scala vestibuli. The patient will still respond, because only thing is the electrode may be somewhere sitting in the scala vestibuli. He will need higher currents, that's all. So, but still it will stimulate. It's not that the patient will not hear, but the anatomy will change, and in the future this child will end up having fibrosis, ossification. Slowly after a few years his responses will come down, and when you try to do an revision implant, then it will be very difficult. So that is why your first implant, and that's why a lot of science has gone into what is happening after you put your electrode in, because it's not just a one-time affair. And grade 4 injuries, you know, when you totally fracture the osseous spiral lamina, so this person will obviously end up in total ossification. So this is a section showing the electrode. So the main difference between a molded array, which is a perimodular array, which has got some memory and it coils, and a free-fitting array, which is a straight array. The main difference is that the molded arrays have got higher chances of going into the scala vestibuli, because once you have put it into the cochlea, how do you know when it turns? So if it turns much earlier, then you would have, like if you are putting in a bigger cochlea, the same length of a molded array, and you have still not beyond the basal turn, and the electrode has start coiling, so it will tear through the basilar membrane and enter the scala vestibuli. You will not know what is happening, but the electrode has gone into the scala vestibuli. That is the main problem with molded arrays. But with a free fitting array or a straight array, you are going along the lateral wall, so it's rubbing along the lateral wall and going, so the chances of injury are much lesser. And as I told you, reimplantation will be difficult if such kind of injuries happen. Just imagine when this child's implant is being pulled out, what it will do to the intracochlear anatomy, and what will happen when you are putting the next electrode in. So all these were studied using different graded stiffness, finite element modeling, and these electrodes eventually were designed having a graded stiffness. That means the apex is very soft, but the base is stiff. So there is graded stiffness from the apex to the base, so that the very gently it goes in. The whole electrode cannot be soft, because then you can't handle it. You're holding the base, the tip will be moving like this. So it has to be a graded stiffness. So these are all ways they tested the electrode. So yeah, so Flex series, which is by Medel, is supposed to be the most flexible electrode with graded stiffness. And now prevention of infection. This is an important point, because you're putting something which is going to be direct communication with the CSF. Okay, so the child should not get an infection or a meningitis. So it is important to plug the cochleostomy, as Satya explained. And why this is important is because in the past, AB had a device with the electrode. They used to give something known as a positioner. So it's like an extra device which you put into the cochlea. And that time the belief was that if you put it along with the electrode, it will push the electrode towards the modulus and give a good stimulation. But then eventually there were a lot of reported cases of meningitis because of this foreign body means an extra device inside, because what they said, the gap between the electrode and the positioner gave space for infection to grow in, and these children had meningitis, and there were 9 deaths because of this. And that time AB went into a lot of disrepute. They had to pull out this electrode out of the market. It was FDA approved, but they had to pull it out, withdrawn in July 2002, and the company had to suffer a lot, but now it's back again. And so yeah, so biotoxicity and biocompatibility, so it's all made up of silicon, medical grade silicon. They have been tested in animals, and humans have shown that it is a good thing. There is a minimal reaction because of the silicon. But what happens is, after you put an electrode, like any other foreign body in the human body, it will develop a fibrous reaction around it, and there will be a fibrous capsule around it, which is known as a pseudocapsule. So this is important when you are doing a reimplantation. When you pull out the electrode, there will be one sleeve of pseudocapsule inside the cochlea. So when you put in another electrode, it has to go through the same sleeve. So now the problem is, you don't know what you're going to put in the future, right? So if you use a very thin and a fine array now, so the capsule is pretty thin. And what if you're using probably a bigger array in the later stage? So we don't know what is going to happen. These are questions which are still unanswered, because we don't have enough patients who have undergone such type of things yet. So all these children who are implanting now, probably by the end of our careers, we'll be seeing all these problems. And as I told you, insertion and reinsertion already. Now insertion strategy. So now see, there was some discussion about Varia technique and posterior tympanotomy. So there is a very important point, that in Varia technique you cannot use molded arrays. Okay, so the latest Cochlear 532 is out. your mid-scala is out, your helix is out, your contour advance is out. Because in a Varia technique, what you do is you first slide the electrode through that tunnel, and after it has reached the middle ear, then you guide it into a cochleostomy. But all these molded arrays come with a stillet, a pin, a wire, or a sheath, which cannot go through your Varia technique tunnel, and it cannot be moved however you want in the middle ear. It has to remain how it is. It has to straight away go into the cochlea, and then it starts uncoiling. So you cannot uncoil it, take it into the middle ear, again recoil it and use it. So all these technological advances which are happening cannot be benefited to the patient using a Varia technique, and half of your electrode options are out once you jump to Varia technique. Of course, in difficult anatomical situations you can use the technique, but this is one of the points which I wanted to stress, because it's not only the surgeon's technique and what he knows and how he can do, or how good he is or how bad he is. It's also about what the companies are doing, what the technology is coming in, whether your technique is adaptable to it or not. So that is also very important. And how do you insert the electrode? Is there are different tools, like how Satya was telling, which can help us as surgeons to guide the electrode very easily into the cochlea. And now there are electrodes which are coming up, in hearing preservation. That means in adults or children who have got good low frequency hearing and have got bad high frequency hearing. So you just want to electrically stimulate the high frequency and leave the low frequency for acoustic stimulation. So these are shorter electrodes basically, and they should be as atraumatic as possible. They are just in the basal turn of the cochlea, and you don't usually go towards the apex. I'll just skip all this. Now just a little bit on the advances in the electrodes. So there was this paper which I had studied when I was in my fellowship, 2011. This was a modular research array being studied by Briggs et al. In Australia, and they were planning to put a sheath around it. And the surprising thing is it's out in the market now. It is launched in 2016 in USA now. It is called the Cochlear Slim Modular Electrode. And so this is what I was talking about. So look at the design of this electrode. It's got a sheath over it. So electrode, it's a perimodular array. It's very thin. It's got a sheath around it. And you take the electrode with the sheath into the cochlea, and then you leave the electrode there and you withdraw the sheath. So the electrode starts going in and your sheath comes out. So all this cannot be done using a Varia technique, because this electrode will not go through that opening which you have made. And this is the latest electrode launched in 2016. Then there are some other, so that is a clinical advance which is right out there in the market. Probably it will come to India in this year or next. And now these are all studies which are having, so basically they are using robots to guide the electrode in, because every human hand has got tremors. No matter how good you are, your electrode is not smooth in. There will be one fine tremor. Only a robot or a mechanical device can send the electrode smoothly in without any jerks, avoiding trauma. Then as Satya mentioned, magnetic guided. So you are using different magnets to guide the electrode in. Now there is also shape memory polymer like nitinol, which is used in which is used in Stapes pistons have it, nitinol. So what it's a memory alloy. As soon as heat contacts it, the piston just contracts. So even the I don't know, the video is not working. So basically what they say is, what happens in this is, when the electrode is going into the cochlea, the body heat will be sufficient for the electrode to start coiling. So if you can see in the video, as the electrode is going in, because of the heat it is coiling. So these are all under study yet, but not out in the market. We don't know whether it will come also or not. So the other advance is there are some drug-eluting electrodes. So I think Cochlear is coming out with this with a drug-eluting array, probably which has got steroid in it, with delayed releasing steroid in it, to avoid intracochlear fibrosis and inflammation when we put the electrode in. Then there are some laser-guided and optical-based electrodes coming up. This all work is being done in Europe, in Germany and Switzerland, where they say that instead of using electricity, we'll use light or laser or infrared pulse laser, which will stimulate the nerve fibers or the spiral ganglion. But the problem with this is they need a lot of high, the stimulation rate is very high, and there may be heat generation because of this, and that can cause intracochlear damage. So this is also under research. And then this is something which has recently come up, published in 2017 September, Otology, Neurotology. There is something known as nano-CI, which is nanotechnology based cochlear implant with gapless interface. No matter where you place the electrode into the cochlea, it will be still away from the nerve fiber. The nerve fiber is not in contact with the electrode. So there is some space, some perilymph between the electrode contact and the nerve fiber, and you are trying to bridge that gap using different technologies. So here what they did is they injected the cochlea of animals with neurotrophic factors, and surprisingly they saw that the nerve fiber actually grew till the electrode contact. So this is something which will change dramatically what the patient hears, because it's like you're stimulating the nerve fiber directly. And this has been achieved now. So they designed an electrode with some channels to inject the neurotrophic factors, and you can see in this is a I think electron microscope view or fluoroscopic view, I'm not sure. So here you can see this is the electrode over here, and this green thing are all the nerve related elements, and you can see there's one green fiber which has grown here. So if this happens, then that means it will give a lot of resolution and better hearing. And this is a multi-center trial, very large trial. I would request you to go and read this article. And so see, this is something which is achievable, not like stem cell injecting and all that. Those are very, 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 very far away. So if a patient asks you that something is going to come, tell them that it will take, by the time it comes, your child is going to lose hearing. So that is not going to happen. It may take another 20-30 years, we don't know. So for now, this is which is the latest thing which can come up. And now why, see, one of the main reasons why an electrode or a cochlear implant is so costly. So devices are like anywhere from between 5 to 6 lakhs and go up to like 14-15 lakhs. So why the cost is so high? The main thing is that the electrode, which is, or the other parts, apart from the microchip which is there in the device, the other parts, the electrode and the receiver stimulator coil are all made by hand. So they're not Indian laborers, they are all in the foreign US and Australia. They have to be paid high, so the cost is high. So this is one of the video when we were in Advanced Bionics lab. We had a chance to make the electrode. So they do it under the microscope. They have different wires, and you have to solder it to these contact points. Okay, and eventually silicone is laid on this, and then an electrode is made. So all this is done by hand. So this is one of the major reasons why cochlear implants are so costly. And so now there is some technology they are trying to make it like a conveyor belt system or mechanized. See, if machines start manufacturing implants, then the rates will definitely drop down. So there is something known as a microfabrication
the electrode
of
arrays that will stimulate the auditory nerve.
And I'm going to spin it onto this silicon wafer. We just use it like a saucer. So we can build our devices on. Dots on it are the electrodes.
So they've got the electrodes like
the
that, which they will
of
attach
the
it to the
arrays
device.
are then sent to a practicing surgeon at Ohio State University to test the devices in human cadaver.
So this is all in testing stage, but if this comes, the prices will definitely drop down. Sorry. Yeah, now the last question, which electrode to select? So like selecting a device is different and selecting an electrode is different, okay? So audiologists play a big role in counseling the patient to tell them which device or which processor to select, okay? Because what kind of resolution they'll have, what are the technologies in the processor, all that is audiologist's part. But if suppose a patient chooses, I want Advanced Bionics, or I want Cochlear, or I want Medal, it is your responsibility to decide which electrode to choose. So how do you select? There are so many things, you just can't go and randomly pick one. So you have to decide which electrode to select. Okay, so how do you select one? This is the summary of my topic. So first thing is you have to see the anatomy and decide whether it's a normal or abnormal cochlea. So it's a normal cochlea, very good. And then you have to decide whether you are going to do any hearing preservation or not. If it's a totally dead cochlea, profound deafness, all the frequencies, then your electroacoustic stimulation or shorter arrays are out. And then you should know the anatomy of the cochlea. What is how big the cochlea is or how small the cochlea is, what kind of length or what kind of depth of insertion you want to achieve. And then after reading the radiology, you can make a decision whether you want to go for a round window or a cochleostomy. Usually thicker electrodes or perimodular electrodes are usually advised to go through a cochleostomy because they need much more space and they have that particular length to go in front and coil. So if a round window insertion may not be adequate. And next is whether a straight or a pre-curved, that is the same thing which I told just now. And what is the thickness of the apex to base of the electrode. So these options are more in Medal rather than other companies. And then whether you want a full or a half banded electrode. So if you have an anomalous cochlea, you have to decide to take a full banded electrode, because you want maximum chance of maximum stimulating the nerve fibers. And next is the flexibility of the array. This is not much important. And you have to think about the special arrays, like what Satya was talking about. There's a form electrode which has got a like a plastic plug at the end. So if you know you expect a gusher, if you have a IP3 deformity or you have an enlarged vestibular aqueduct and you're expecting a perilymph gusher, then you opt for that electrode pre-op rather than struggling inside. And the last thing is what insertion technique you're comfortable with, or maybe as a beginner you're doing one company and you're comfortable with one kind of insertion. So you probably continue that and later on start doing other things. And then the last one of the more important points which I just added now is the surgical technique and financial status of the patient, because even the cost of the electrode, even my battery is low now, so even the cost of the electrode, it changes the cost of the implant to around 80,000 to 1 lakh. It will change depending on which electrode you choose. And obviously surgical technique, if you're doing only varia and you don't do posterior tympanotomy, then half of your electrodes are out. So you have to choose the electrode as per that also. Yeah, these are some of my references, and thank you. And I'm happy to take any questions. Okay, thanks a lot. Yeah. Sorry. Yeah, ask. On? Of cochlear implants. Okay. Okay. Okay, so post-op care, if it's a routine case and nothing has gone wrong inside the OT and everything is fine, next day you take a X-ray to reconfirm the position, and then the child is usually discharged the next day. We don't keep the child more than 1 day. Just a perioperative dose of antibiotic is enough, or maybe till the child is discharged, because this is a clean case, okay? And then the patient can be put on oral antibiotics. At least we put it, but a lot of setups don't. They just give the injectable and leave it. And then the child's bandage is usually removed after 5 days to 1 week, and you see how the suture site is, or even you can remove it before 2 to 3 days. It is very flexible, and if the wound has healed properly, then you decide when to do a switch on. So a switch on can happen. So some people are doing next day switch on in Europe and all, and some people are doing after 2 weeks, some people after 1 month. But the ideal thing is you see the wound. If the skin has healed and everything is fine, there is no edema, if post-op edema has settled, then you can put the device and do a switch on. And the question about facial paresis, if the patient has got facial paresis, and you will know it when you're doing your electrode, sometimes your shaft rubs onto the facial nerve when you're drilling the cochleostomy, and that heat can cause some facial paresis, which will eventually recover. We usually give dexamethasone, probably three doses. One is intra-op dose would have been given once in the night, once in the morning, and the patient is discharged. We don't continue the steroids, and most of them recover. Unless you have severed the nerve or it was an anomalous cochlea, there's nothing to be worried about facial paresis. Yeah, and post-op steroid we give, that's what I told. Yeah, any other question? Yeah, so vestibular implants have come. They have done at least I think 3 or 4 cases in Netherlands, I think 20 cases in Netherlands. So it is actually designed by Medel, I think, no? Cochlear. Yeah, so both of them are doing it. So it basically has got 3 electrodes, which each one of which goes into one of the semicircular canals, and basically ampulla of the semicircular canals, and each one has got a gyroscope, and the gyroscope is basically which detects the movement in respect to gravity. So you have so one is enough actually. As we know, one vestibule is enough for us also. If the patient has got Meniere's disease or whatever, and one side vestibule is gone, after some exercise and all, they usually manage with one. So if a patient needs a vestibular implant, the patient should have areflexia. Both vestibules should be out. So the patient has got both side vestibules are gone. So then only he is a candidate for a vestibular implant. And so these 3 electrodes are put in the ampulla, and each electrode gives a electrical stimulation to the ampulla by the movement detected by the gyroscope. So the gyroscope detects the movement. So you don't have a speech processor and all that. Gyroscope is inside the device, which is under the skull, and it detects the movement and gives a adequate stimulation to the. I don't know if there is a device or not. I'm sorry, because I don't know how they're going to power it. And and that's how it is. So it's not yet come into commercial use yet, but they have done some cases. Anybody? Okay, thanks a lot.
sir. Now I request Dr. Satya Kiran sir to please come ahead and felicitate Dr. Manu Sruth and Dr. Praveen. Now I invite Mr. Shiva Prasad Bodupalli, Chief Audiologist and Clinical Specialist in Cochlear Implants from Shravya Speech and Hearing Center.
Good evening, everyone. I'm Shiva Prasad, audiologist from Shravya Speech and Hearing Center. Now I'm going to cover hearing screening, newborn hearing screening and its importance. So before getting into the presentation, I would like to play a silent national anthem. So please stand for this national anthem for just 2 minutes time. Thank you. Please sit. So how many of you followed that completely? So that's a silent word. So if you see that any hearing impaired, how do they communicate? Any deaf people, deaf persons, before we call it as deaf people, deaf mute people. So how do they communicate? With sign language? So do you understand what they are talking, what he is talking, what they are trying to communicate? So it's for us, it's very, it's impossible to communicate with them. It's impossible to, unless if you're trained, then you'll be able to follow that signs. Otherwise, it's very difficult. So how many of hearing impaired are into sign language? So if you see overall in India or throughout the world, sorry. So in India, close to out of 1,000 newborns, around 3.8. That means close to 4 people in 1,000 kids are born with severe to profound hearing loss. And every year, close to 1 lakh children are born with hearing impairment. So most of these kids, if we are not identified at the early stages of in their life, they all will become speechless. So we need to identify them as early as possible. So if we identify in early stages of their life, how they will be. You just see, I'm just going to show 2 patients, 2 clients who are into mainstream now, who are, just see these patients. So this first one is Arya. He was identified at the age of 1 year and underwent implant for 1 year. Sorry.
లేదండి రెయిన్బోలో టెస్ట్ చేశారు. నేనే అడిగాను ఒకసారి టెస్ట్ చేయండి, చేసేవాడు బాగానే ఉందన్నారు. అదే దీంట్లో ఉన్నాం అనమాట. 1 ఇయర్ అప్పుడు నాకు డౌట్ వచ్చింది. వీడు 2-3 మాటలు అనేవాడు, అప్ప అని, ఆ పాతో వచ్చేవేవో అనేవాడు. మేము అయ్యే మాటలు అనుకున్నాం. 1 ఇయర్ అప్పుడు డౌట్ వచ్చి ఫస్ట్ నేను శివప్రసాద్ గారికి కాల్ చేస్తాను. మా పిల్లలిద్దరికి ఆయనే ముందు నుంచి చూస్తున్నారని, ఇయరింగ్ లాస్ అయితే ఉందని చెప్పారు. తర్వాత అప్పుడు వాడికి ఒక 1 ఇయర్ 2 months అలా ఉందండి.
నా ఫ్రెండు పేరు సాయి. ఆయనకేమో ఆయన చాలా బాగా ఆడతాడు కబడ్డీలో. ఇప్పుడేమో మా ఫ్రెండ్ ఉంటాడు, వాడు 7th క్లాసు. వాడేమో కబడ్డీ అంటే వాడిని ఇట్లా పట్టుకుని ఇట్లా లాగేస్తాడు, చెట్టు పట్టుకుని ఇదిగో ఇట్లా లాగేస్తాడు. ఇట్లా లాగేసేసి ఇంకా అంతే, ఇంకా వదలడు, తర్వాత వదులుతాడు.
సరే అప్పుడే ఒక తెలిసిన సార్ చెప్పారు, ఢిల్లీకి ఆస్ట్రేలియా నుంచి ఎవరో వస్తున్నారు, ఒకసారి అక్కడ కూడా మీరు చూపించండి అన్నారు. సరే ఢిల్లీలో కూడా ఒకసారి చూపించాక వాళ్ళకి సర్జరీ చేయించండి, కరెక్ట్ ఏజ్ మళ్ళీ ఏజ్ అయిపోతుందంటే ఇప్పుడు శివప్రసాద్ గారి దగ్గరే మనం ఫస్ట్ రైట్ ఇయర్ చేయించామండి. అసలు ఆ 2 అక్షరాల మాటలు చెప్పడం కానీ, ఒక 1 ఇయర్ వచ్చేసరికి అసలు మంచి స్పీచ్, పెద్ద వర్డ్స్ చెప్పడం, ఎక్కడ ఏది చూసినా ఎవరు ఏది మాట్లాడుతున్నా వీడు ఏదో రెస్పాన్స్ అయిపోతూ ఉండేవాడు.
I have 3 friends at my home. 4. And first one is Sai is my friend, and Anand is my friend, and Kumar is my friend, and Srinu is my friend. But Sai is my best friend.
ఒక యానిమల్ గురించి చెప్పాలనుకోండి జూకే వెళ్ళేదాన్ని. ఇప్పుడు ఏదైనా ఒక వెహికల్ గురించి చెప్పాలనుకోండి, ఇక రోడ్లమ్మట తిరుగుతా ట్రాఫిక్ పోలీసుల గురించి, రోడ్ల గురించి, ఆ సినిమా వాల్ పోస్టర్స్ అప్పుడు గబ్బర్ సింగ్ ఏదో రిలీజ్ అయింది పవన్ కళ్యాణ్ది, అలా ప్రతి వర్డ్ ప్రతిదీ వాడికి ప్రాక్టికల్గానండి. నార్మల్లేనండి. ఒక మ్యూజిక్ వాడికి అంత క్లారిటీ ఉండదేమో అని చెప్పారు, కానీ వాడికి మ్యూజిక్ కూడా బాగా క్లారిటీ ఉంటుందండి. అసలు ఏది ఇది క్లారిటీ లేదు అని ఉండదు.
Who are you? Dun 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 boom boom boom. Who are you? Dun 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 dun. The dil sa sara pucha sala. Who are you? And next song, fluff fluff fly, mama my, boom boom boom. Who is that guy? Boom boom baba, boom boom baba, boom kampala shabdalai. It's laughing time.
సపోర్ట్ చేశారు. సుప్రసాద్ గారు రెగ్యులర్గా మానిటర్ చేసేవారు. అన్ని విధాలుగా వాడికి అందరూ సపోర్టేనండి. కాక్లర్ ఇంప్లాంట్ వల్లేనండి ఇదంతాను, లేకపోతే ఇంత ఇంప్రూవ్మెంట్ రాదు కదా. ఇప్పుడు నేను చెప్పేదంతా ఇంప్లాంట్ వల్ల వచ్చిందనే చెప్తున్నానండి. దాంతో మేము కూడా ఏంటంటే ప్రాక్టికల్గా చేద్దాం, వీడికి ఒక రూమ్లో కూర్చోబెట్టి ట్రైనింగ్ కాదు అని అంతా ఓపెన్ ప్లేస్లోనే వాడి గురించి నీ కోళ్ళని పెంచాము, కుక్కల్ని పెంచాము, ఆవుల్ని పెంచాము. ఒక వెహికల్ గురించి చెప్పాలంటే ఆ బొమ్మలు కొనేయడమే. ఇదంతా వాడికి ఫస్ట్ రైట్ ఇయర్ కదండి, చాలా బాగా స్పీచ్ అంతా డెవలప్ అయిపోయింది.
ఇదిగో నువ్వేమో ఇట్లా పట్టుకుని ఇదిగో ఇది వదిలేసి కాలు పట్టుకోవాలి, ఫాస్ట్ ఇది వదిలేసి కాలు పట్టుకోవాలి. ఓకే, ఇంకొకటేమో చూడు ఇట్లా వస్తున్నాడు కదా వాడేమో నువ్వు ఏమనమాక ఇట్లా అంటాడు కదా వాడు. సపోజ్ నువ్వు వాడి కాళ్ళు ఇట్లా పట్టుకు ఇట్లా అంటాడు కదా, ఇదిగో 2 చేతులు ఇట్లా అంటాడు కదా, సడన్గా పైకి లేగి ఆ చేతులు పట్టుకుని ఇట్లా లాగి తర్వాత లెగ్స్ ఇట్లా లాగి కాళ్ళు పట్టుకుంటే ఇట్లా అంటే వెనక్కి వచ్చేస్తాడు.
మొన్న విజయవాడ ఎయిర్పోర్ట్లో వాడు వైజాగ్ ఫ్లైట్ అనౌన్స్ చేస్తుంటే, ఏంటి స్పైస్ జెట్ వైజాగా, మనకు స్పైస్ జెట్ హైదరాబాద్ కదా, అసలు అంతా వాడికి క్లారిటీ ఉందండి. వీడు ఎంత బాగా క్యాచ్ చేసేస్తున్నాడోనండి. ఓ పక్కన తింటున్నాడు, తింటూ కూడా అంత కాన్సన్ట్రేషన్, నాకు చాలా హ్యాపీ అనిపించింది.
So Arya was implanted at the age of 1.5 years. Now he is almost 9 years. He is into mainstream, attending normal school. So we have one more client. I'm just showing here for example. So sorry. And that was Arya at the age of 1 year surgery, and she is Bhavana. She got implanted at the age of 22 years but identified at the age of 3 years only, used regular hearing aids. Then at the age of 22 years, 23 years, she underwent implant for both years.
Hi, నా పేరు భావన. మాస్టర్స్ ఇన్ కంప్యూటర్ సైన్స్ చేస్తున్నాను ఇండియానా స్టేట్ యూనివర్సిటీలో.
తనకి చిన్నప్పుడు హియరింగ్ ప్రాబ్లం ఉందని చెప్పి డాక్టర్స్ చెప్పారు. మామూలుగా అందరి పిల్లలకి వచ్చినట్టు మాటలు వచ్చేవి కాదు భావనకి. ఒకసారి స్కూల్లో జాయిన్ చేశాక వస్తుంది అని చెప్పేసి అందరూ అంటే అలా 3 years వరకు వెయిట్ చేశాము. అసలు అమ్మ అనేది కాదు, అమ్మ నాన్న అసలు అనేది కాదు.
డాక్టర్స్ చెప్పారు లైక్ హియరింగ్ ఎయిడ్స్ వేసుకోమనేసి, వాళ్ళు చెప్పినట్టు వేసుకున్నాను నేను.
ఈవెన్ స్కూల్లో తనకి ఛాలెంజెస్ వచ్చాయి, అంటే ప్యూర్ మేట్స్ అందరూ కొంచెం సతాయించిన చేసిన, బట్ షీఈస్ నెవర్ గివెన్ అప్ ఆన్ దాట్.
చెప్పాలంటే ఇంటర్ దాకా బాగానే ఉండింది నాకు. తర్వాత ఇంజనీరింగ్కి వచ్చినప్పుడు కొంచెం కొత్త లైక్ హియరింగ్ లాస్ ఉండేది. ఇంకా పెరిగే కొద్దీ ఎవరికైనా అనిపిస్తుంది కదా లైక్ అందరిలాగా మంచిగా వినిపించాలి అనేసి. నేను హియరింగ్ ఎయిడ్స్ చేసుకున్నప్పుడు నేను నిజంగా లిప్ రీడ్ చేసేదానని కూడా నాకు తెలియలేదు. క్లాస్ రూమ్కి వచ్చేసరికి నేను ఎప్పుడూ ఫస్ట్ బెంచ్లోనే కూర్చుంటాను.
In the journey of this 23 years, there were quite many challenges like hearing aids. Every 3-4 yearsకి నేను అప్గ్రేడ్ చేసేదాన్ని. యూఎస్కి వెళ్ళిన తర్వాత మేబీ ఆ వెదర్ కండిషన్స్ కనుకుంటా చల్లదనానికి 2 years స్పాన్లో చాలా లాస్ ఎక్కువ అయిపోయింది.
నేను భావనను అరౌండ్ 3 months బ్యాక్ చూశాను. తనకు లాస్ట్ 2-3 years నుంచి హియరింగ్ లాస్ గ్రాడ్యువల్గా ఇంక్రీజ్ అవుతున్నట్టు, తనకు కమ్యూనికేషన్ ప్రాబ్లమ్స్, ఈవెన్ విత్ హియరింగ్ ఎయిడ్స్ షీ వాజ్ నాట్ ఏబుల్ టు హియర్ ప్రాపర్లీ. సో అప్పుడు మేము వేరియస్ టెస్ట్ చేసిన తర్వాత తనకు మోడరేట్ సివియర్ టు సివియర్ హియరింగ్ లాస్ 2 చెవుల్లో ఉన్నట్టు నిర్ధారించాము.
క్లినిక్లో టెస్టులు చేసి స్పీచ్ పర్సెప్షన్ చూసాము. సో ఆ రిజల్ట్స్ చూసిన తర్వాత స్ట్రైట్ అవే ఇంప్లాంట్ ఈజ్ బెస్ట్ ఆప్షన్ అని చెప్పాము.
కాక్లియర్లో ఒకటి చేయించుకుంటే ఒక సైడ్లో మంచిగా వినిపిస్తుందని చెప్పారు, ఇంకొక సైడ్ నార్మల్గా ఉంటుంది అనేసి అన్నారు. నేనేమనుకున్నానంటే 2 చేయించుకుంటే మంచిది అనుకున్నాను. లాస్ట్కి ఇంకా మా పేరెంట్స్కి కూడా చెప్పాను, లైక్ గట్టిగా చెప్పాను చేయించుకుంటే 2 చేయించుకుంటాను అనేసి.
So Bhavna went with both the ear bilateral. She got it done for both her ears and she is actually doing awesome.
జూన్లో సర్జరీ చేశాము. రికవరీ కూడా చాలా స్మూత్గా ఉండింది. తనకు లాస్ట్ టైము మేము చూసినప్పుడు కంప్లీట్ నార్మల్గా వినికిడి, అంటే ఒక నార్మల్ పర్సన్ లాగా వెనుక నుంచి మాట్లాడినా సరే లిప్ రీడింగ్ అవసరం లేకుండా కంప్లీట్ ఎలాంటి హీరింగ్ డిఫెక్ట్ లేకుండా ఉండింది తను.
15 డేస్కి స్విచ్ ఆన్ చేసాము. స్విచ్ ఆన్ చేసిన తర్వాత స్లోగా వినడం అనేది స్టార్ట్ చేసింది పాప. విదిన్ ఏ వీక్ డ్యూరేషన్లో ఆ సౌండ్స్ వినడం, అర్థం చేసుకోవడం కూడా జరిగింది. 2-3 మ్యాప్స్ తర్వాత వైర్లెస్ యాక్సెసరీస్ కూడా ఇవ్వడం జరిగింది. ఫోన్ క్లిప్ కానివ్వండి, టీవీ యూనిట్, మినీ మైక్, వీటన్నిటితోని బయోలాటరల్గా వింటున్నప్పుడు అంత ముందుకున్న భావన విదిన్ 2 months డ్యూరేషన్లో భావన కంప్లీట్గా చేంజ్ అయిపోయింది.
నేను హియరింగ్ ఎయిడ్స్ పెట్టినప్పుడు కొన్ని పదాలు నేర్చుకోలేనివి ఇప్పుడు నేర్చుకున్నాను. నేను ఇంతకు ముందు నాకు అసలు అవి ఏమి వినిపించేది కాదు. ఇప్పుడు ఏంటంటే నేను క్యాన్సర్ పెట్టుకున్నప్పుడు లైక్ వర్డ్స్ కూడా క్లియర్గా అర్థమయ్యేది అనమాట నాకు. నేను సంగీతం క్లాస్ జాయిన్ అయ్యాను. యాక్చువల్గా చాలా ఇంట్రెస్టింగ్గా ఉంది, ఒక్కొక్క సౌండ్ ఎలా ప్రొనౌన్స్ చేస్తారు ఏంటి అనేసి. ఇంతకు ముందు నేను హియరింగ్ ఎయిడ్స్ చేసుకున్నప్పుడు నాకు నిజంగా మా ఇంటి బెల్ సౌండే వినిపించేది కాదనమాట. సో యా, నేను నా రూమ్లో ఉండి కూడా బయట బర్డ్స్ షిఫ్ట్ చేయడము, ఎక్కడో లైక్ ఇంకో నెక్స్ట్ కాలనీలో గట్టిగా మాట్లాడటము, వెహికల్ సౌండ్స్ రావటము, అవి బాగా వినిపించేది. అండ్ థియేటర్స్కి వెళ్ళి కూడా లైక్ యూనో ప్రతి ఒక్క డైలాగ్ అర్థమయ్యేది నాకు. అసలు సబ్ టైటిల్స్ కూడా ఇంకా చదవట్లేదు. ఫోన్ కాల్ వచ్చినా కూడా జస్ట్ ఇక్కడ ఉంటే ఒక బటన్ ఆన్సర్ చేస్తే మనకి ఇక్కడ డైరెక్ట్గా వినిపిస్తుంది, చాలా క్లియర్గా వినిపిస్తుంది. అసలు ఇట్స్ లైక్ రియలీ హ్యాపీ అన్నమాట.
సర్జరీ అయ్యి తను రికవర్ అయినప్పటి నుంచి ఒకసారి కూడా రిపీట్ చేయాల్సిన అవసరం పడట్లేదు. దట్ ఈస్ లైక్ రియలీ బ్లెస్డ్ అని అనుకుంటున్నాను. భావన మ్యాపింగ్ మొదలుపెట్టిన తర్వాత సెకండ్ డే తను నా దగ్గరకు వచ్చనింది, మమ్మీ నడుస్తే కూడా శబ్దం అవుతుందా అని నాకు ఇప్పటివరకు ఎప్పుడు తెలియదు అని. దాట్ వాజ్ లైక్ సో ఎమోషనల్. అండ్ తను బ్రేక్ఫాస్ట్ చేస్తున్నప్పుడు మమ్మీ ప్లేట్లో స్పూన్ పెడితే ఇంత శబ్దం అవుతుందా, ఇట్స్ సో అనాయింగ్ అనేసి. మనం ఇంకే దానికంటే కూడా చాలా ఎక్కువ వింటున్నారు వాళ్ళు. ఆల్ ఐ కెన్ సే ఇస్ థ్యాంక్ యూ సో మచ్ ఫ్రమ్ బాటమ్ మై హార్ట్. థ్యాంక్ యూ.
Vande Meena.
So if we see the first 2 videos and the next 2 videos of the kids, a major difference is identification, early identification and early intervention. First 2 slides, they could not speak anything, they are into their own world, that is 0.5%. They used to communicate with only sign languages, so they are not into the mainstream. But the other two slides, 2 videos, they are identified at the early stages and they are treated with whatever is required, whether hearing aids or the cochlear implant, and they attend a regular therapy, then they are into mainstream. So early intervention and early identification is very important, very crucial to become a normal speaking person. So just as an introduction, I just want to let's hear from Dr. Janardhan sir. What about regarding cochlear implant?
Cochlear implant అనే పరికరము పూర్తిగా వినికిడి లోపం ఉన్న వారికి ఉపయోగపడే ఒక ఇన్స్ట్రుమెంట్. అది తొందరగా డయాగ్నోస్ చేసి కొంచెమే హీరింగ్ లాస్ ఉంటే హీరింగ్ ఎయిడ్స్ ఇచ్చి, టోటల్ లాస్ ఉంటే ఇంప్లాంట్ చేస్తే అప్పుడు ఈ చిల్డ్రన్ అలా హ్యాండిక్యాప్డ్ చిల్డ్రన్గా పెరగకుండా నార్మల్ చైల్డ్గా పెరిగే అవకాశం వస్తుంది. ఈ ఇంప్లాంట్ శస్త్రచికిత్స చేసి థెరపీ ఇచ్చి కొన్నిసార్లు మ్యాపింగ్ అడ్జస్ట్మెంట్స్ అవి చేస్తే కానీ అప్పుడు వాళ్లకు మన మాటలు అర్థమయ్యి మళ్ళీ వాళ్ళు కూడా మాటలు నేర్చుకుని మాట్లాడే అవకాశం ఉంటుంది. ఇమీడియట్ కాంప్లికేషన్స్ చాలా తక్కువ ఛాన్సెస్, లైక్ 1 to 2% ఛాన్స్ ఉంటుంది. ఇన్ఫెక్షన్ది కానీ, బ్లీడింగ్ కానీ, లేకుంటే పరికరం పనిచేయకుండా ఉండటం కానీ, అవన్నీ ఆర్ ఇక్కడ నర్వ్ వస్తుంది ఒకటి ఫేషియల్ నర్వ్ అని, ఆ నర్వ్ డ్యామేజ్ కావడం అవకాశం కానీ చాలా తక్కువ ఛాన్సెస్, లైక్ 1 to 2% ఛాన్స్ కంటే ఎక్కువ లేదు ఏ కాంప్లికేషన్. సో 98% చిల్డ్రన్ నెక్స్ట్ డేనే డిశ్చార్జ్ అవుతుంటారు.
So early identification, what is the incidence of this hearing impairment? So if you see out of 10,000 kids, born kids, so around 30 kids are born with hearing impairment, that is severe to profound hearing loss. In 10,000 kids, close to 30. Whereas if you see the other problems like cleft lip and palate, Down syndrome, limb defects, other problems, issues, it's comparatively very less. If you compare with cleft lip and palate, it's around 12 here out of 10,000 kids, only just 12 kids. Whereas for hearing impairment, it shows it's actually 30, but it's around almost 30 to 60. Few studies says it's almost 4.8 or 3.8. In AP and Telangana, few studies shows that, you know, it's out of 1,000, close to 6 kids are born with hearing impairment, severe to profound hearing loss. So what is the, if you see the in hearing impairment, reading comprehension, if we see it, if they are not identified at the early stages, for a normal hearing person, this is a normal hearing perception, reading comprehension. So over a period of time, chronological age, as the age progresses, their comprehension will be increasing with the age. Whereas for hearing impairment, as they can't hear anything, they are not identified or they are not treated. So because of this hearing impairment, they are not able to perceive like a normal person. So over a period of time, the reading comprehension will be very poor. The same way in their, this is different. So here I am showing you the unilateral hearing loss. One ear is completely normal and opposite ear is severe to profound hearing loss. That is unilateral hearing loss, single side deafness cases. If you see the single side deafness case also in normal schooling situations, this is a normal and this is the unilateral. These are the different studies with different subjects. If we compare with the normal kids, there's a difference, statistically significant difference with unilateral hearing loss. So if it's a bilateral hearing problem, there'll be huge difference. So if you see the performance is very poor even in unilateral hearing loss cases. So even in these cases, we need to identify at the early stages and then we need to give a treatment. So when to identify? So these are actually copied from Dr. Janardhan sir slides. So 1-3-6 rule. At the age of 1 month, we need to screen the baby and identify. By the age of 3rd month, we need to confirm and diagnose the kid. By the age of the 6 months, we need to start intervention. Whether we can give hearing aids and then speech therapy, see for some time. Then if it's required, then go for the other options. So what is early intervention and what is delayed? So if you see here hearing screening, if you see Indian scenario, so in other countries they identify by the age of, they screen the kids by 1 month, but whereas in our situations it's around 12 to 18 months. Parents will identify and then they'll bring to the hospital. They come to the ENT surgeon. By the age of confirmation around there, it's around 3 months. Whereas here 18 months to 24 months, and treatment starts by around 2 years here. So that is very much delayed. So how to identify these kids? How to identify? So there are 2 tests which are which has to be done by birth itself. That is OAE, autoacoustic emissions, and BERA. So autoacoustic emissions is, we put one probe into the ear canal. We give the stimulus. With that stimulus, there will be movement of the outer hair cells. Because of that movement, there will be some echo will be generated, that movement. So that echo will be comes back to the ear canal. That will be picked up by the microphone in the external ear canal. So that will be shown outside. So that is measured as autoacoustic emissions. So factors which affects the autoacoustic emissions, it's a 2-way transmission. So first thing is noise. So ambient noise should be controlled, and then patient noise, that is breathing and movements or swallowing, sucking, this noise, and then internal equipment, internal noise, or probe, if it's not fitted properly, even that will generate noise. So you need to be very careful when we put the probe. So that is probe fitting. And then advantages of OAE is it's a screening or diagnostic application and highly sensitive, site specific, that is outer hair cells thing. And the next is do not require any behavioral cooperation from the subject. Then it's a ear specific, highly frequency specific, that is in DP distortion product OAE, and do not require a soundproof room. We just need to have a quiet room and can be very quick, as low as 30 seconds to 1 minute duration, and it's a portable. And limitations with the OAEs are it's susceptible to noise and affected greatly by the middle ear status. Only information about the outer hair cells, we won't get the information about the other parts, and maybe some absent or abnormal OAEs, even in normal cases also sometimes. Not detectable with hearing loss less than 40 decibels. If it's 40 dB, less than 40 dB with SN hearing loss, we do get OAEs, and not measured with not measure of neural or central auditory pathway, and it's not a test for the hearing. That's a OAE. So we need to have a combination of both OAE as well as BERA test for the screening. So ABR we can have diagnostic tool or else automatic ABR. So AABR. So this is actually system based. So what we do is we put the headphone, we give the stimulus. When we give the stimulus, there will be action potential will be generated. That action potential will be picked up by the electrodes placed on the scalp, and that will be measured, and see we'll measure the action potential in wave 5, wave 3 and wave 1. So it will be measured like this. It's used for differential diagnosis, and it's a screening procedure for newborns, diagnostic tool for diagnostic tool, and estimate the hearing thresholds exactly. And it looks like this after measurement. Right ear and left ear we have will get a peak waveform like this. This is wave 5, wave 3 and wave 1. Same way in right ear and left ears, individual ears. So we need to have both OAE as well as the BERA test to rule out or to screen the babies. So we need to screen by age of 1 month, and by the age of 3 months we need to diagnose the kid, we need to rule out, and by the age of 6 months we need to start the treatment by giving a hearing aids or speech therapy, whatever is required. So if we identify at the early stages, that is less than 6 months duration, so we have a small study. So if we see here, this is a chronological age and this is a expressive language scores. If we see here 1 to 1.5 year, actually there is no difference, but whereas if you, as the age progresses, when they are identified at the age of below 6 months, so the scores are high. If you see here 2.5 to 3 years, up to 3 years, if you see here, the scores are high in when they are identified, diagnosed less than 6 months duration in expressive language scores. If you see the overall vocabulary size, if you see the vocabulary size also, at the early stages there is no difference, but as the age progresses, if you come to around close to 3 years, so there is a huge difference. This is identified early stages, below, I mean less than 6 months, here after 6 months. Same way, early intervention in language, if you see, there is a difference. So we need to identify as early as possible by using OAE and BERA. So when they identify early, so they will be able to talk like a normal person. So previously we used to call as deaf and dumb. Deaf is actually given by God, and dumb is man-made. So any doubts on this? Any queries? Anything related to hearing screening? Yeah, please. Yes, sir. Sir, we are associated with few hospitals. We are doing newborn hearing screening, like Little Star Children's Hospital. We are doing newborn hearing screening, and we even started in Kim's Hospital. Not all the hospitals, it is not there. I think Rainbow is doing it with Sai Krishna. We are also doing in few hospitals, but not in all hospitals. What we do is within when they are born, within first week of duration, what we do is we do the OAEs first. First we do the OAEs, and then we'll observe for 3 months duration. After 3 months we will follow it again. So we'll do the, if they are failed, within 15 days we'll redo the OAE within 15 days. If they are passing OAE, so after 3 months we will check it whether they are responding well or not. But the follow-up, to be frank, is very less. So if we get any high-risk babies, or if it's failed, something like that, within 15 days we are doing BERA also. First thing, when we started 3 years back, sir, in Little Stars Hospital, when we started there, first of all, parents used to say, no, everything is fine, we don't have to do anything, he's fine, why to do this test? Even we used to do it for free of cost. Then we started charging it. Then people, a few people started, okay, fine, they are allowing it. But when we started with free testing, when we started 3 years back, we thought, chalo, people, they may not be interested, we'll do it for free of cost only. But when we are doing for free of cost, it was not, actually they are not recognizing it. But when we started charging them, people are motivated, and then we are doing it now. Yeah, please, sir. Tell me, sir. Yes, sir. Automated is. Yes, sir. Yes, sir. Yeah.
6 months, you can intervene, that is correct. But cochlear implantation better
After. Yes, sir. I do agree. I do agree, sir. As per FDA, it's a 12 months. Recently, I have been to one conference, sir. Yeah, I do agree. So what they said was, though the FDA approval is 12 months, they are doing from 9 months onwards. 9 months, not less than 9 months, from the 9 months, because of the scalp thickness and the, yes, exactly. So 9 months, from 9 months they are doing it. Why I said 6 months is when we start with 6 months, at least child will start wearing a hearing instrument and will be able to see the responses, whether there is any response or not. But it's a BERA. When we do the BERA, though we do the BERA diagnostic protocol also, it's not exact accurate response. I consider that as 80% of the responses. So let's say it has, say if you are getting a response at around 100 decibels, 100 dB, if you are getting BERA peak, I won't say that as a 100 dB response. Maybe child may get even 80 decibels also. 20 dB, we can take it as slightly lesser. So that variation is there. So it's not accurate response like pure tone audiometry. Pure tone audiometry is 95% accurate responses what we get it, but through BERA it's close to 80%. So when we do BERA in a young babies, if we can identify that, we give a trial for at least 3 months duration or 6 months duration, and parents has to accept that the child has got problem. So those things will take time. So if we identify at the age of 12 months, it will prolong up to almost 16 months, or yes, confirmation is by 3 months. Yes, yes. Yes, sir. Yes. Yes, exactly. 1000 Hz, sir. Usually, 1 second. See, when I say as a screening tool, to be frank, though we do it practically, if we consider we do it OAE, but when I say technically, if I'm considering as a screening tool, I need to consider both OAE as well as BERA test. So to rule out whether the child has got hearing problem or not. So we need to have both the things, OE and BERA auto ABR, at least auto ABR, set it at around 50 dB or 40 decibels, do auto ABR. If you are getting the peak, then that's a pass. If not, follow up or go for the diagnostic tool. I do agree on that. High, yes, yes. Adults. Maybe around, I consider around 6 months duration, sir. 6 months. I do consider around 6 months duration. Thank you, sir. Any more doubts? Thank you. Thank you, sir.
Thank you, Mr. Shivaprasad. Now I invite Dr. Praveen sir to please come ahead and felicitate Mr. Shivaprasad. I now invite Ms. Deeksha Rayapati to come ahead.
Good evening, everyone. I am Deeksha. I am an audiologist from Shravya Speech and Hearing Center. Today my topic of presentation is post-cochlear implant process and rehabilitation. How to go about with the rehabilitation. So, thank you. Yeah, thank you. So going in detail about the post-implant services. In cochlear implant there are basically two parts, the external part and the internal part. The internal part, which is the electrode array, that is surgically implanted, and there starts our role, putting the external part, mapping it, and doing the rehabilitation services, which is auditory verbal therapy. So post-implant services begin as soon as the implant is inserted into the cochlea in the OT itself. That is called the intra-op responses, measuring the intra-op responses. This is very important. And the next process is the switch on of the external part. Then comes the mapping and troubleshooting of the processor, and then the auditory verbal therapy. These are the things that we deal with, apart from the pre-implant counseling. So coming to the intra-op measurements, once the cochlear electrode array, implant electrode array is inserted inside, it is very important to know if the electrodes are functioning properly before the closure of the skin itself. So when electrode array is nothing but it's an electronic equipment where current should be flowing. So whenever there is a current flow, there is always a risk of short circuit or an open circuit. So as there are there are many electrodes, we have to check the flow of current. This is called the measuring of impedances. So these impedances are measured, and then along with that, the neural responses for each electrodes are also measured. Electrodes are nothing but each and every electrode will be given a frequency band. So each frequency band will be put in the form of tonotopicity of the cochlea itself. So it is done immediately after the electrode array is placed inside the cochlea, and to know if all the electrodes are placed inside and they are working well. and it is also to measure the responses for the electrical stimulation. We will also know if all the electrodes are present inside the cochlea. These measurements also are used for further mapping sessions post-operatively during the switch on and during the mapping sessions later on. So this is how a general intra-op measurement looks like. So the horizontally the 22 numbers indicate the 22 electrodes which are inside the cochlea. Starting with 1, it is the high frequency, and 22 is at the apical end, which is the low frequency. So generally for doing the intra-op measurements, the external processor is put in a glove and handed over to the surgeon so that it is placed on the magnet at the receiver stimulator level. So then the measurement has to be done. So it is always important to shorter the time to avoid the infections because it is not closed. So we do the intra-op measurements is done for at least 3 to 5 cochlear electrodes. We start with the 22nd electrode, go to the first electrode, then come back to the middle electrode, then another 2 electrodes, at least 3 to 5 electrodes covering all the 22 bands. So then we can extrapolate them later on. So if the electrode 22, 16, 11, 6 and 1 are eliciting the responses, it indicates that the whole electrode is inside. So this is the way that electrical responses are measured, and the wave. So this is how the response is indicated with a negative peak and a positive peak, while the and all this is happening automatically. This is how the intra-op NRT is done. In different companies, it is known as with different names. In one company, it is neural response telemetry. In other company, it is neural response imaging, and so on. It differs. So then, once the intra-op NRT is done, it's closed, and the patient is left for 2 weeks for the healing to happen. So once the healing is done, generally it is either 2 weeks after the surgery. If the healing is taking time, 21 days is more ideal. So the process of placing the external part of the cochlear implant, which is the sound processor, is nothing but doing the switch on. So this is done after 2 weeks of the surgery. So sometimes it's 3 weeks also. Following the surgery, the implantee will return to the clinic to have the external part fitted. And this particular fitting process is called as switch on. So during the switch on, there is always a misconception that once the switch on is done, the child will be starting to hear, but that will generally not happen. Just to give you a simple example, if a person is going to a fitness center and if he wants to go for a weight training, and if the trainer has to pull 100 kg weight at a time without any training, he would not be able to do that, because the muscles and the nerves, they should be trained to slowly get used to weight training. In the same way, the electrode array which is inside, the nerves have to be trained to take the current. So once, if we give the whole, to get to the stable map level, to give a normal hearing level, if we give so much current levels during the switch on itself, the patient will just take out the processor and throw it away, and will never wear it again, because it will hurt. It's painful. So we start with a very low current level and slowly improve the current levels session by session, and it will at least take 2 to 3 months to reach the actual stable map in which the child will be able to hear normally. So this is the process that happens. So mapping, that process is called as mapping. Mapping is the term given to the process of measuring the amount of electrical current delivered to the cochlear implant. So there are 22 electrodes. Not every electrode will not have the same amount of current level to be stimulated. Every electrode will have its own current level to get normal hearing in that particular frequency band. So that current, the process of giving that current, electrical current is nothing but doing mapping, where the softest sound is identified, the comfortable sound is identified, and map is set accordingly. The loudness levels that we give will vary on the dynamic range given between the soft level and the comfortable level. So this process ensures that the patient will receive a comfortable level of loudness and auditory percept. So the map, it is a complete set of instructions that is given to the sound processor, which will include the stimulation level, that is the current level that has to be sent inside, because whatever levels that we set, that is the that we do it in the sound processor level. So that sound which is mechanical is transmitted inside, and it is converted to electrical signals at the level of receiver stimulator and sent to the electrode array. So that stimulation levels has to be set during the mapping session. There are different stimulation parameters to be set. There are different speech processing strategies depending upon different companies. And this will enable the processor to output the data in a form which can be decoded by the receiver stimulator and change it into the electrical impulses. So there are two ways in which mapping is done. For very young children below 2 years old, 2.5 years old, when mapping is done, mostly we use the neural response telemetry responses, because the child will not be able to behaviorally tell if the sound is, if the child is able to hear that sound or not. So then in that case, NRT responses are very helpful, which will create a baseline from where we can start the setting the map levels. And the next procedure is the behavioral responses, where the child is conditioned to hear the sound and respond to it. So that is called as conditioning. So where the child will hear the sound and respond to that sound. We go in either an ascending manner or a descending manner, where we start at a little higher level and come down to a level where it is where there is a 100% response in that particular current level. So that is considered as the threshold of the hearing. So from there we set the map levels. These are the two methods where mapping levels can be set. So how frequently the mapping is required? So initially, yes, initially the number of mapping sessions will be more, because to get the stable map itself, it will take at least 2 to 3 months. So initially on the first switch on day, we generally processors have, it will have a option of giving 3 or 4 maps at a time. So 4 different maps with 4 different levels with increasing current levels will be given, and the child will be asked to come back after 15 days. So after 15 days, a little more increase will be given in the current level, so that child hears a little more better. In that way, it will be generally for most of the children, it will take 2 to 3 months for this process to happen. Later on, they can come in every 6 months or 1 year, but they have to come back for the mapping sessions at least in 6 months or minimum once in a year. So that is very important, because there will be changes in the cochlear fluid, so the map levels can change and the speech clarity will be varying. So every year mapping should be done that will retain the speech clarity and hearing clarity. So along with mapping, one more important thing is the troubleshooting. There are a lot number of models in sound processors as well. So each sound processor is different from the other. They'll have different buttons, different coil cables, magnets, coils, batteries, rechargeable, disposable. There are a lot of things that are there in the sound processors. So the problem should be exactly identified when a child is not able to hear. If the problem is with the processor, where exactly the problem is there in the processor, so that has to be identified. So that is nothing but troubleshooting. So it is to identify why a processor is not working, as there are various parts in the speech processor and various models of speech processor. It is very important to get down to the actual problem of it, identify it and rectify it as soon as possible, because we always recommend, not like hearing aids, we always recommend implant to be running 24/7 unless the child is sleeping. So it is very important to get down to the problem as soon as possible. Then comes auditory verbal therapy. So this starts after 15 days of switch on, generally because initial 15 days the MAP levels are very, very low, the child may not be able to hear anything. So after 15 days, auditory verbal therapy starts. So until cochlear implant or hearing aids, any amplification is done, the child is deprived of the sense of hearing. So generally any child will start hearing sounds when the child is in the womb itself. So immediately after the third trimester, the first trimester, the child will be starting to hear. So if the child is not, after birth, if the child is not here, is not intervened for 1 year, the child is deprived of hearing for 1.5 years, because 6 months in the womb, the child was also not able to hear. So because of this, it is very important to identify it early and intervene it early, because child will lose the habit of hearing naturally. So generally hearing sense, all the senses are, it becomes a habit of using them. So the child will not have a habit of using hearing at all. So in such cases, we have to make the child to learn to listen to what is around them. So they do not use the hearing for so many years, so they do not have a habit of hearing. So it should be it should be a habit. We have to inculcate it as a habit into the child's everyday environment. So child should now learn to listen. ABT will help the child to make the child a natural listener. So the goal of auditory verbal therapy is that the children who are deaf or hard of hearing can grow up in a regular learning environment, enabling them to become more independent, participating and contributing citizens into the mainstream. So the more important goal of all this, going for a cochlear implant, going for therapy, everything is to get the child into a mainstream, either into the education or in his careers. So they have to be more independent. That is the main goal of auditory verbal therapy. So it is the way of guiding the parents to teach their children with a hearing impairment to develop spoken language by stimulating the hearing that is given by the cochlear implant. So why guiding parents is, speech therapy, any auditory verbal therapy session is for 45 minutes a day, that's it. So all the other time is spent at home with parents or at school. So parent approach is very important. There are children who are, we generally see where children who are identified and implanted at the age of 2 years or 1.5 years, but if the parents are not putting their effort at home for therapy and for making them speak, the response in those children is lesser than as opposed to the children whose parents will continuously keep talking to them, engaging them into communication and in general conversations. Those children have more outputs in speech and language than compared to the children where parents' support is less. So this will guide the parents to how to go about in language development at home. That is what we do in auditory verbal therapy. So there are different stages of development, auditory development, where the first step is the awareness of sound, to be aware that yes, there is a sound, whatever it may be, there is a sound, that is the awareness of sound. Then associate the meaning with the sound. Then imitation and expansion, where when the child is able to speak 30 or 40 words, we generally prefer joining them and making into phrases and then sentences. So, and then the comprehension, where effective responses to the language. So these are the different listening scales: sound awareness, environmental sound test, 6 sound test, that is called the link sound test. I will get into that. Then the localization, discrimination, identifying the rhythm, suprasegmental is rhythm, intonation of the sound. These are the first things that generally a normal hearing child will first pick up. So suprasegmentals are always very important along with the speech and language development. Then coming to the word level, then into the sentence level, then to the discourse, which is conversations. So so all these different electrodes, different frequency bands, these are all because all our speech sounds lie from 125 to 250 hertz to 8000 kilohertz. So all our speech frequencies, speech sound frequencies around the world, they generally lie between 250 hertz to 8000 hertz. So when they have made the intensity of the sound and frequency matching, this is the way it looks like. It looks like a banana. So it is called a speech banana. So if you can, if we see these sounds, oo, ah, e. So E is at the range of somewhere in the mid frequency. Nasals are somewhere between the low frequency and mid frequency. Oo is a very low frequency sound. S, sh, f, the, all these sounds are high frequency sounds which are called fricatives. So depending on the, and with implant we make sure that the child is able to hear all these speech sounds within the speech banana. When they are able to hear within the speech banana, that will help the child to develop language because he is able to hear all the sounds properly. So this is the speech banana, and 6 sound link test is nothing but this is a fundamental test that we do for every implant child to make sure that the child is able to hear all the speech frequency range, because A and oo are a low frequency sounds, E is a mid frequency sound, sh, s are high frequency sounds, is a low frequency sound. So we make sure that the child is hearing all the frequency range every day. So we at least ask the parent to, if the speech clarity is less for a child on a particular day, we ask the parent to make sure to do this test at home or anywhere the child is. So this is again made as a conditioning response. So these images are just to make the child active and to make it in a play session. So why AVT is important? Generally for a normal child, if we see, by the age of 36 months, it's around 3 years, the child will be able to at least have 1200 words in their vocabulary. So if the child is implanted and if the child is having therapy, the amount of vocabulary that they learn along with auditory verbal therapy is more than the child implanted and without therapy. Without therapy, the number of words that they learn will be quite less. So therapy becomes important to get them to the normal children's vocabulary level. So and the main, so one more thing which is important is, for a normal child to register a particular word, the child has to hear that particular word for 40 times, that particular word for 40 times in 40 different sentences. So that is the general for a normal hearing child. So how it will be definitely more for a hearing impaired child. So whenever we counsel the parent, we always tell the parent that this important it is that the child has to be always in a speech and language and a conversation zone. So the parents should be always motivated to talk to the child and keep the child in a hearing environment of speech and language hearing environment. So different variables that affect the outcomes is the age at which the child is diagnosed, the causes of hearing impairment, degree of hearing impairment, audiological management, the health of the child, that will also affect the language development of the child, the emotional state of the family participation, which is very important, the skill of the therapist of course, and the skill of the parents, and child's intelligent and learning style, because not every hearing impaired child may be with a normal IQ. There are special kids who have hearing impairment along with a little lower IQ or some kind of a learning disability also. So for those children, the expectations should be a little lower. We have to counsel them, counsel the parents during the pre-implant counseling itself to what to expect and what not to expect. Yeah, thank you. Any questions? Sir. Yes, sir. Correct, correct. Sir, it's not straight. Thirty-two.
Never the same. It is near normal but not the normal. Yes. If we plot post-implantation threshold levels like a speech banana, like a SPL levels of a curve type, will it be nearing the normal level? 1 second. Near not. This is not true. No, sir. It is not.
Generally, it is, and there are also studies that say this, if the responses are lying within the speech banana, once we do the, generally for conditioned children, we do an aided audiogram after the mapping is done, sir. So if the levels, if the aided audiogram is lying within the speech banana, their clarity is a little bit lesser. The as compared to the children where the responses are lying above the speech banana. So speech banana is most of the sounds are below 35-40, but if the responses are at 30-35, then the child's hearing is much better. The speech clarity of the child is also much better. So they have to be above the speech banana only, not at the level of speech banana also, sir. I haven't answered.
What category of auditory performance? CAPD, CAP code. Not CAP. Okay, there are two things here: central aortic crossing disorder and CAPS code. CAPS code we don't do. We do it speech perception scores. Speech perception.
We more rely on subjective responses rather than objective. Thank you, sir. Thank you so much. Thank you. Thank you for giving me this opportunity, sir. Thank you.
Thank you, Ms. Diksha. Now I invite Dr. Vijay Praveen sir to please felicitate Ms. Diksha. Now I invite Dr. Manu Sruth, Dr. Satya Kiran and Dr. Somashekar to please come forward and felicitate our organizing secretary, Dr. Vijay Praveen sir, and our senior faculty member, Dr. Yogender sir.
I hope this CME was very helpful to all the delegates. I'd like to propose vote of thanks. I thank Professor M. Srinivas, our Dean, and Medical Superintendent, Mr. Dr. K.K. Paul, for their constant encouragement, financial support, and the beautiful premises. I'd like to thank all the speakers for giving their valuable time for this CME. And I would also like to thank Professor Dr. L. Sudarshan Reddy, President, AOI Telangana State, for gracing the occasion. Dr. Srihari, Medical Superintendent and HOD ENT, Ramachandrapuram ESI State Hospital. Dr. Satish, he's the HOD ENT at Nacharam ESI State Hospital. Thank you, sir. And I also like to thank Trinet Live channel for making live transmission of this entire CME, and also making the entire video accessible and downloadable. It will be available on YouTube. There were many delegates who are watching it online from Vijayawada and Vizag. They have mailed me thanking me. So I would like to give special thanks to them. And finally, all the delegates for coming all the way and hearing patiently. And finally, I'd like all the delegates to collect the CME certificates near the 250-seater auditorium. Thank you, one and all.